Members, can I just first of all wish you all a Happy New Year. Welcome to our first meeting of 2024. Can I ask for apologies for absence, please? Any apologies?
Thank you, Chairman. I'm substituting for Councillor Trevor Clark tonight. Thank you.
Thank you very much, Councillor. And Councillor Pearce, you're covering for Councillor Crozier. Can I ask members, can I sign the record of the meeting held on the 7th of December as correct record, please? Is that agreed? Thank you very much. I have no urgent business to announce. Are there any disclosable pecuniary interests or other significant interests or any declarations of whipping this evening at all? Okay, thank you. Okay, before we move on, can I also ask that those introducing reports this evening should assume that members have read the reports presented and please aim to keep the report introductions reasonably short and hopefully no longer than 5 minutes, maybe just focus on highlights if possible. So first item on the agenda, number 5, is the Henton Medway NHS and Social Care Partnership Trust, KMPT, and we've got Adrian. Welcome back, Adrian. Hope you're feeling well. Could you just give us a highlight of your report? And I think you're doing it in partnership with Jackie, is that correct? Okay. Adrian, over to you.
Thank you, Chair. Good evening. Obviously, I'm joined by Andy Cruikshank this evening, who is our Chief Nursing Officer for KMPT. And as you mentioned, the paper has been written in collaboration with Social Care, and Jackie is happy to take questions as well on that. The paper, obviously, I will take as read. We've set out to describe the patient pathway for those patients who are admitted to our acute hospital beds, as requested at the agenda setting meeting. We describe in the paper the different routes into our acute beds, which are multiple different routes into it. We also touch upon some of the secondary mental health services that we provide in the community as well. We detail some of the initiatives that we are working closely with our acute providers and across Medway to try to reduce, to improve on flow and discharge, including at the door triage in our emergency departments and our co-located safe havens. We also detail some other initiatives in collaboration with the ICS and our voluntary sector. For those admitted to our inpatient hospital beds, we give some of the demographics in terms of the proportion of male and female patients. We do note that there's a slightly higher proportion of females across Kent and Medway that do require admission. Within Medway, it's around 50-50, but that does have some impact on our acute colleagues at MFT with regards to the female waiting times for admission. We have put countermeasures into place in the last week with regards to that to try to address some of that disproportionality as well. The paper also details some of the ethnicity and to note that while there is a higher proportion of patients admitted who are identified as mixed or black ethnicity for Medway, I would draw the committee's attention to the fact that the NHS national proportion, there's quite a large proportion, around 10%, that actually say with no details. So we read into that actually our recording is somewhat better than the national with regards to ethnicity. We've also included some brief updates with regards to the workforce that care for the patients and our vacancy rates for both our younger adults and older adults. And our turnover for December, our turnover staff for those patients for those staff who care for patients in the acute setting was 15.7%. Now, there was a question from the previous HASC with regards to how that is calculated, and I've confirmed with our Director of Performance that is a retrospective 12-month overlook. So the 15.7% represents the amount of staff turnover from December 22 to November 23, which is in line with national standards. We also include some details with regards to our discharge processes and our challenges that we receive with our discharges. We do note that our Medway patients do have slightly longer length of stay compared to Kent patients. However, they still do remain below the national average as well. And we also include in the report some of the challenges, but also some of the initiatives that are underway to try and reduce discharges and those clinically ready for discharge. We've also been requested at the end to also include some information with regards to our safeguarding activities at KMPT. And I would note that our referrals for both children and adult safeguarding have increased throughout the last 5 years. We remain committed to Think Family approach, and we also have included some of the initiatives looking at closer working, collaborating with the Kent Police Crime Commissioner for aspects such as our Health Independent Domestic Abuse Association advocates. I will pause there. I'm not sure if Jackie wants to add anything to the introduction or if you'd like me to go on to questions.
Jackie, nothing to add? And welcome, Andy. Sorry I didn't welcome you as well. So I'm opening up to members, please, on the paper. Any questions? Councillor Campbell.
Thank you, Chair. Thank you for this report. I found it really positive. It's so great to see all the initiatives in place, especially things like directing people away from emergency departments to, I think that's so crucial. I have been there in emergency departments waiting to be seen, and then to see people come in crisis and the staff not necessarily know how to handle that. I mean, it's very distressing, the whole situation. So to have them redirected to more appropriate services, that's an excellent initiative. And all the crisis beds, the safe havens, this is all excellent. This sounds great. What I want to ask is I want some reassurance about how this information will be disseminated across all your teams and across members of the public, because I often speak to people, and in my own experience, the landscape is forever changing in terms of where people need to go for help, what that help looks like, which number to call, which service to go to. And I always encounter a level of confusion, even amongst staff at these places. And then I mean, a lot of mental health support comes from referrals within communities, you know, like you're talking to somebody, your neighbor. For example, I helped a neighbor of mine who was severely ill with mental health issues, and I had to find out where she could go and what services. So I think there's something you have mentioned about communications. I've read that here about sending that message. I just want some reassurance that there'll be a mapping of behaviors of people, of where they seek information and how they access that, so that you know, all of this work is not lost because people don't know what to do. And the other point I wanted to say is I'm glad you mentioned non-white communities and how, you know, the numbers, it's actually really positive. I was surprised because from my experience, there's still a heavy stigma around mental health issues in non-white communities. My own community, for example, people don't like to talk about it. So the stats here are more reflective of the demographic, actually, of the split of white and non-white. So that's actually really encouraging. I was quite pleased to read that. So thank you.
Thank you, Councillor Campbell. Other members?
Thank you, Dan. So yeah, my question is more relating to what I've heard from residents. They kind of are saying that they are being spoken to by various organisations about how they feel about the mental health services in Medway, but what they're saying isn't being listened to. They're not being heard. So first question is, what are you doing to make assure these residents that they are being listened to? I've had comments just in this week. Mental health system is rubbish. The mental health system makes us feel like objects and like property. In regards to hospitals, they feel dehumanised. They felt there's no compassion at hospitals. They felt it should be a safe place, but they don't feel that is how it is at the moment. Yeah. So, how much of this do you feel is true, and what kind of other measures are you doing to address this for these residents? That would be my first question.
So I'll take that question and perhaps pass to Andy if he wants to add anything on that. So I think you're absolutely right. We do need to make sure that we continue to engage with all of our patients and the communities that are out there, and really seek their advice and their help with co-production of services. And we do remain absolutely committed to that. Just this week, one of our board committees signed up to a review in the next to draft the next 5-year strategy for how we look at patient engagement, patient involvement in the services, but also reviewing the quality of services that are already being provided. We mentioned in the paper as well about our community mental health framework transformation, which is a huge piece of transformation which works across both us as a provider, but also a number of voluntary sector and other providers that will be rolled out across Medway and the rest of Kent in the coming year. Some of that was already underway in Medway, but paused. But we launched a new trailblazer in Thanet just this week as well. A lot of that will be looking at bringing people together and having that input close to home, and making sure that we do listen to them and have that regular feedback loop to make sure that we adjust what we hear from those patients and those relatives that are experiencing our care or who want to experience our care. Our pause, I'm not sure if Andy wants to add anything to that.
Thanks. Hello, everyone. I guess just to add, around the inpatient side of things, the hospital care. So these are very, very busy services with a very high demand, and we know that some people get quite scared when they come into those environments, and that in itself, I think, creates a climate for individuals about not necessarily feeling they can engage with the care that's on offer there. But we also know that historically there's not been the level of investment, particularly in inpatient care, in terms of looking at things like therapeutic offers, therapies, that kind of thing. So we have injected a lot of new funding into that. And there's quite a lot of transformation work actually going on within the inpatient site itself, making the environments friendlier for people with autism, for example, and picking up on those people who arrive in crisis but don't necessarily need to stay with us for very long. It could be 2 or 3 days, but making that meaningful. Sometimes I think people experience it as a very short, not necessarily helpful stay, because in a way it's a way of taking stock and then thinking about what comes after the admission. The admission is a sort of pause point in their life to try and work out what we do next to help. And on those occasions, I think people can have a very mixed experience of what it's like. In contrast, though, we have people who get tremendous benefit from our inpatient care and talk about that quite freely. So always work to do on that, I suspect, but there is a very clear, as there is with the community work, a lot of transformation work that is within the inpatient settings as well. Key to that really is about how we talk with people and engage with them, and that goes from, well, just the routine things about what your interaction with a clinician might be like, but going back to the previous councillor's point about how you get access to that. Now, it's fair to say with the transformation work, we're probably going to have a bit of a bumpy road to work out exactly what's needed where when we get down to that neighbourhood level and understand what people actually need and make sure that those things are accessible and known and that that information stays up to date. Part of the transformation work is clearly to work more with the charitable and voluntary sector to think about how we can partner in a different way with them, and that's across the county, to get best value in terms of what works for people where they live within their neighbourhoods, so that it doesn't necessarily feel like you have to go through lots of referral processes to find out where you need, or rather to find out where you need to go, and then problem with referral processes, they can take a lot of time and you may not get the help that you were anticipating at the end of that referral process. You might be directed somewhere else. We want to remove as much of that as we possibly can to make sure we get earlier help to people nearer to where they live. That's the primary objective. But that does mean we're going to have to map all of that stuff out. And I think, as you were inferring, it can be quite complex to work out what's available where and how that works. And if it does what we need it to do at the standard, we need to do it.
Jackie, you want to add to Councillor Shocker's question?
Thank you. Yes, so I'm a member of the Community Mental Health Framework Programme Board, and we were talking yesterday about the changes that are taking place across Kent and Medway. And one of the questions I asked is about how we're going to let people know. So not just our residents, but social care, other partner organisations. I'm meeting with a member of Adrian's team and a colleague from Kent County Council to think about that, how we can roll that out. Because it's the same from a social care perspective. At the moment, we talk about community mental health team, and we need to be making sure that we are referring people to the right places. So that's a piece of work that's just about to start from a social care perspective.
Thanks, Jackie. Councillor Shocker, do you want to come back, or are you okay?
Yeah, I'm fine. That's all right. Yeah.
Sure. Okay. Thank you. Councillor Wiley.
Thank you, Chair. Excuse me. You talk about not early discharge, but discharging the patients earlier than the national average. Why do you think early is good? And if the national average is higher, then if you're an outlier, are you getting rid of them because, and I know I'm phrasing that badly, but are you discharging them because of the shortage of beds, or are you discharging them as you see at the right time? And one of the reasons I ask that is later on the agenda we have Kent Medway Safeguarding Board, the Adults Annual Report, which has some of the adult reviews in there. And reading that, at least 2 of them appeared to have been discharged early with unfortunate consequences, and I think that's a bad way to phrase that as well. But there's a question in there if you can pick it out.
Yes, certainly. I think when we talk about lengths of stay in hospital, what we're trying to work out is, are we making somebody's time in hospital as effective as it can be, and does that give enough time to prepare for what comes next when they leave? In this area, in Kent and Medway, we have a lot of very short admissions. So that's people who are going through a very brief period of crisis as opposed to having necessarily a severe mental illness. For those people with more severe mental health problems who may be detained under the Mental Health Act, they will have a much more prolonged stay in hospital over weeks and maybe months, and in some cases years. So there's not an urgency around discharging anyone in that sense. What there is about is what we would argue is really effective use of our resources and our beds. Now, on the point of, is early discharge by definition risky? Not by definition, no, because actually the vast majority of discharges, I mean, we're characterising it as early discharge, but actually that's not really what we're talking about. We're talking about timely discharge, when people, A, want to leave hospital, and B, when they're ready to leave hospital. And we need to facilitate that, particularly if they're informal, we've got no necessarily control over their actions and no right to impose anything upon their desire to leave hospital. So that's quite a large proportion that people look after. There are those cases you mentioned from safeguarding. Now, we take that extremely seriously, as you can imagine, to understand exactly what went wrong there and make sure we've got things lined up for people. So we have discharge coordinator roles within our hospital settings to sort of tee those things up, which we didn't have before. They're sort of new additions to our resourcing to make sure that we're not missing key components of somebody's aftercare when they're discharged. Is it always perfect? It probably isn't, because people don't necessarily always interact with what is on offer, but actually we want to make sure that we're giving the best possible chance for them to do so.
And can I ask another question on you talk about domestic violence in here. Do you, it seems to me that women and girls often get mentioned, whereas men, and they do get abused, they don't get the same sort of priority or mention, or that's the way it feels. Do you see it that way, or how do you provide for men?
In the same way we provide for everyone. I mean, I guess the key thing for me, from my position, is when you look at the safeguarding data, you see it going up. Now, some people might be disturbed by that and thinking, well, is this situation worse? I think from a therapeutic perspective, if you feel that you're in a relationship with somebody who's offering help to you, that you can trust them to respond to your needs, it's a really strong signal that we're doing something right, that people feel confident to say, this has happened to me, I'm really concerned about this, or that it's noticed, staff begin to notice patterns in behaviour or interaction, that then they can develop a conversation with those individuals to ask about their safety and to think about what they need. Now, that's the same for men and women. I think it's true to say that by far and away the lion's share of abuse in this respect does happen with women by men, but actually that doesn't mean that we don't detect this and work with men when they declare that this has happened or they disclose that this has happened.
Okay. Thank you again.
Councillor Cook.
Thank you. Thank you very much for the report. Really interesting reading. A couple of bits that jumped out to me. Section 5.8 talking about the number of referrals, and then on into section 6.1, which I guess for me was about then that planning of those who have been referred or who have entered your service but then need that more intensive care. And curious about that snapshot date, about patients that weren't able to be in area, and how you go about planning for that around, is that a usual date? Why that date? How far are people going? How usual is that? But then secondly, kind of related to that, but perhaps a second question, if that's okay, in terms of one demographic. Thinking about Medway specifically, and as we were preparing for tonight, thinking about physically this area and the number of young people who come into Medway as students, so adults, under this committee, but the amount of kind of added pressure that there is for young adults who are coming in to use our universities, to use our colleges, and whether that puts a particular pressure on your service and how you particularly support that demographic within Medway in terms of your planning for their needs. Thank you, Chair.
So I'll pick up on the first question, if I may, and then pass over to Andy. So with regards to the snapshot, I think the data was just literally as the report was being written, so we chose that date. The 6 out-of-area beds are for psychiatric intensive care beds. They are predominantly normally female beds because we do not have any inpatient female ITU beds within Kent and Medway. So we work with our providers to make sure that we secure them. In terms of what we do to make sure we keep that monitoring, those 6 beds are that's a rough number that we normally experience throughout a chunk of the year. But we do make sure that we work really closely to make sure that anybody that is placed out of area is brought back into area as soon as possible. That's normally done 3 or 4 times a week, just to make sure we do that. And we have very close visibility on that at executive level as well. I'll pass to Andy for the piece on the mobility bit.
Yeah, well, just to add to the intensive care unit, so it's actually unit at Seven Oaks, or near Seven Oaks, that we use. So it's not outside of the county. We class it as out of area because it's not part of our services in that respect. That doesn't mean that we don't have to, when we've got very high demand for, and it is intensive care, it's not actually our admission beds, sometimes have to go further afield to find a bed. We try and keep that as close to Kent and Medway as we possibly can for obvious reasons about keeping in contact with family, loved ones and so on. So by and large, the position is pretty good in that respect. Ideally, we would have our own intensive care unit for women. We don't at the moment. Whether that will happen in the future, we'll see. But that's that situation. In terms of the student population and the demand on services for them, so that's really not so much of an issue. I mean, we do have some inpatient need from that group, but it's not huge. And we find that the younger end, in terms of our demographics, it's actually when you get into your early to mid-20s, the demand for inpatients tends to go up. This is more about what's provided within the community. Now, the university themselves provide care for individuals, and of course anyone who's at university who might become unwell tends to go back to where they came from. It's better to go home to receive treatment if that's the preferable and safest option for you to do that. Our community teams will work with students though as required, particularly if they're on a pathway to recovery from a problem, or they've got a long-term mental health problem that needs monitoring. Our community services will work with them around that. It does rather illustrate, though, I think, in terms of why we need to do the transformation work to make sure that we've got a better connection with what's the sum total of what's available for people in the community, because we will find that somebody may be referred from or referred themselves through the GP at the uni to our services. And they'll have to wait several weeks in order for us to see them. Might be the usual is about 4 weeks. But actually, if there's something more immediate that could be available to them, that's more connected with that GP service, that would be preferable. And that's the kind of work that we really need to make sure that the transformation delivers.
Councillor Llewellyn-Prenton.
Thank you for making it clear about the ethnicity, because I did wonder about that, the extra. I've got a couple of questions. First one's about an engagement exercise by the VCS called Kent and Medway Listens. Did you take into account the responses from that when you redesigned the services? Another one is regarding the pressure on the recruitment, particularly for the older adults. It seems to be you're under more pressure than they are nationally. Is there a particular reason locally? So is it benefits or the conditions of work? And then the final point was for Jackie, really, and that was about the care homes, because you mentioned before about, obviously we're under pressure for people getting into care homes. You mentioned a place in Wigmore, and I just wondered if there was an update. Is that operational? Are there any more places? Could you just provide an update, please? That's it, thank you.
I'll probably handle the second one, and I may pass to Andy and then to Jackie, if that's all right. With regards to the recruitment, it is slightly higher for our older adults compared to our younger adults at the moment, but it's very slight compared to national average. I think it is once again, it's multifactorial with regards to the location, trying to get the skill set. As well. I think some of it is also due to some of the facilities that we've had up until now in terms of where we want them to be and the sort of the quality of service that we can provide. We've got our new ward that will be opening next month with regards to Ruby, which is, we're hoping, going to be a real pull for older adults and older adult nursing as well. I'll pass over to Andy for hopefully the first one. The Kent Medway Listens.
If I'm honest, I don't actually know the answer to that question. What I do know is we've been closely involved with Health Watch colleagues and a number of other stakeholders around this in the design of the community mental health framework. I think the central framework is something that is mandated nationally. How we implement that, though, is the bit that we need everyone's engagement with. And the benefit of having the health and care partnerships means that we've got a much better route into understanding population needs and picking up on that in new ways. But that is, I can't answer that from that specific piece of work. I'm assuming yes, but that's an assumption and it may be wrong. So sorry about that.
Absolutely. Councillor Prenton, your mic, please.
Obviously, the group have asked the local people, and that's who we're interested in particularly here. So.
Absolutely. I can find that out.
Thank you.
Yeah, thank you. It was very timely because one of our commissioners went and visited the home last week. It's due to open, or they're planning to open, in the beginning of February, so first couple of weeks of February. It's a 73-bed home, a nursing home. So a substantial care home for Medway. And the feedback is that it is superb, it's got excellent facilities, somewhere you'd really want your family member or loved one to go. So the commissioners are having discussions at the moment about costs, etc. Normally when you have a facility of that good, it's costly, but they're in discussions with them. They've got residents lined up already, only about 5 or 6. So it's coming forward, and we're in discussion.
Councillor Prenton, just briefly,
Yeah, just quickly, sorry. The 73, is that going to be mixed with people who are paying for their own care, or just right? Okay, so it's literally whoever can fill it.
I mean, for the provider, it's a provider that looks for self-funding people in the main. But that's why we're having the discussions, because whether you'd actually be able to fill 73 beds with people who are self-funding, and obviously what they will do is they will look to London and other boroughs, so that's why we want to have the conversations early to see if we can do anything about some block beds or something like that.
Thank you, Chair. Sort of going back to what you were mentioning, Andy, just as we was coming out of COVID, sat on a committee that was trying to get users' views, and they were doing a pyramid scheme and about risks. So for people who had autism or similar neurological difficulties, they could put themselves on a register that, and they would then, it would help them not become an inpatient if they had a mental crisis, because it was seen that people with autism and other conditions were harder to discharge because of the plan after they came out, so that they could register onto this, they could register onto the register, and they could alert someone that they felt that they were going into crisis, so a plan could be put round to stop their discharge being delayed. But as I said, I did this just coming out of COVID, and I haven't heard anything about it, so I didn't know if it had gone, but I just thought it was a good way of you saying about people with autism taking beds.
Yeah, it's fair to say that inpatient mental health units are not great environments for people with who are neurodivergent, particularly with autism, just simply because of the nature of those environments. It's very stimulating, there's lots of noise and activity that actually can be very disturbing for people. So as a in terms of primary need, they're not the environment for somebody with autism. Does that mean that we sometimes have to look after, because you get lots of co-occurring conditions, so you can be anxious and depressed and have autism and psychosis and things like that. And so those environments, we do have to look after some people, and that's the work we're doing about how can we optimize those environments. The built environments were never built with the needs of those individuals in mind back in the 80s, etc., where a number of our inpatient units were developed. What we do know is, so what we want to have is clearly a really good community resource for people with learning disability and autism, to make sure that they don't then tip into needing our services in crisis. So there's a lot of work with colleagues, both within KMPT and within the local authorities, looking at how we provide that in a more holistic and joined up way. Part of that is making sure that you've got an understanding of what individual needs are, and in particular that, in my world, we call it more of an advanced directive, saying if I tip into crisis, this is the thing, these are the things that work for me. Don't do that thing that will be unhelpful, because you're absolutely right. Once somebody goes into hospital, particularly if their needs are complex, and bearing in mind most people who do go into hospital with autism do have complex needs, they can end up having quite protracted admissions, because we're trying to find the best way for them to exit hospital into a provision that's really going to meet their needs. And of course, the best way forward is to try and avoid that crisis in the first place. And that's where we need tools such as the passport kind of idea you're describing, to make sure that we can avoid that if at all possible.
So just to clarify that, there is something like this now in place, like the passport, as you said. It was sold as a pyramid thing to me, that it went up and then...
I know what you mean. I'd need to talk to... we've got some people who lead on this work. How mature that work is, I'm not sure. That was the intention, to make sure that we were really listening to the community around that, individuals within the community who are engaged with services. But how mature that work is, I don't know off the top of my head. I'll have to go and find out.
And again, obviously, when the discharge actually happens, that we put a proper support network round, because if someone with autism that has gone through a crisis and then coming back out the other side might need a little bit more support than they went in with.
Yeah, and I guess what we are finding is people are being admitted in crisis to our services who didn't know they were autistic.
Yeah.
And so then we have to think with them about what they need going out. And it's just making sure that we're as joined up as we can be with everyone, other services, families, loved ones, etc., about what the best course of action needs to be for those people. It's not always easy. Some of the needs of individuals are quite high, so it does take time to find the right provision, one that we're confident is going to be able to look after the needs and isn't risky. That's the kind of thing. That's really that's why some of those admissions are are so prolonged. That's very difficult, though, because we know that those admissions are not necessarily yielding any one particular benefit by that point. So there is urgency, but of course we want to make sure that things are safe.
Okay. I suppose I just wanted to highlight that fact and say
Thank you.
thanks.
Thanks, Councillor Jensen. I'm going to go to Councillor Nain, then finish with Councillor Wildy. Councillor Nain.
Oh, thank you, Chair, and thank you for such a detailed report. First of all, I would like to take this opportunity to applaud the Kent Police and the Crime Commissioner for the introduction of the FN Independent Domestic Advocate in December 2021. Because sometimes we overlook the good works that the police is doing. So I think I would like to applaud them for helping you to come up with trying to solve domestic violence to reduce mental health. But my main question is with regards to the data on the ethnicity of patients accessing inpatient and NHS services. Looking at it, it's like in Medway, we have 13% of blacks accessing that service. I just want to find out, is there any reason why the number of blacks accessing it is high? Is it because maybe what is leading to a lot of blacks to access that service? If looking at the other communities, and in Medway it's 13% for the black community. And then the second bit is, how did you come up with the figures? Is it that we took the total population of the white community, the black community, the Asian community, and we did find the percentage, or it's just the general percentage of people just accessing the service?
So I can answer the first question. I think we might need
looking at the ethnicity of patients accessing inpatients NHS services, we have 13% of blacks. And I want to know why is that in Medway we've got a higher portion of blacks accessing that service. Is there any reason to it?
So I think, once again, it's probably multifactorial. I think it does represent the slight difference in diversity with regards to Medway and Kent. If you look at the ONS statistics of 2021, there was a higher proportion of black, Asian, and those reporting of mixed ethnicity in Medway compared to the rest of Kent. Also, when I mentioned earlier with regards to, I think actually at KMPT, we're really quite good at actually capturing that data as opposed to other organisations and other NHS trusts where they may then just divert to a not known as well. So I think it's partly representative of the population of Medway. It's also partly representative of the more accurate data that we have at KMPT compared to the national average. I think there's also, obviously, there's the epidemiology with regards to mental health and the predominant risk of patients who are from black and other ethnicities having an increased risk of mental health as well. So I think there are two or three of those factors that could contribute to that. I'm not sure if Andy has anything else to add for that.
Not particularly. I mean, I guess it does reflect the population, I think, pretty reasonably. But it is an interesting point about, and it is the question we ask a lot about, are we looking at this in the right way? Are we thinking about the needs of the population? And this, again, gets back to I feel like I'm a bit of a cracked record, but it does get into the community mental health transformation work and actually understanding our communities a bit more and looking at what we need to do and how we need to join up with organisations in the community to see if there's anything we can do earlier that might prevent somebody having to come into our care and that kind of thing. But I guess it's all the things that go with the social determinants of health. So it's it's all the stuff that affects every population around whether there's stable employment, whether you've got stable housing, whether you've got family support networks, relationships, those sorts of things. And an important facet of what we'll be doing as we move into the transformation work is instead of simply looking at diagnostic frames for people saying you've got this condition or that condition, we'll actually be working with people to look at their quality of life across a range of measures. And that will give us a good indication of where and how we need to change the way that we interact and intervene with our communities. I think that's going to give us some really, really interesting information about how we can work across the entire sector, but in particular, how we work with the black and minority ethnic communities in Kent and Medway.
Thanks, Andy. Councillor Lang, could you just turn your microphone off, please? Thank you. Councillor Wildy, to finish off before over to me.
Thank
Councillor Wildy, you want to turn your microphone on, please?
Thank you. You talked about out-of-area placements and mentioned Sevenoaks. Does that mean we now don't have anyone in Liverpool, etc., further afield like that? And, of course, everyone in an in-bed is out of area to Medway because you've closed all of the Medway beds. Right. Can you comment on that and answer the furthest that people are for out of area?
Do you want I'd have to have a look at the to see where the furthest away is. The last was somebody in a specialist placement up in Northampton was the last one that looked at. Otherwise, we don't have anyone from our adult acute sector out of county at the moment. We've got, as I say, there's an intensive care provision element that's provided over in Sevenoaks, but that's what we have just now. They're
in a specialist care because that's the best place for them, not simply because of numbers of beds.
Yeah, that's right. And when people do go out of area, we actually have a team who specifically go to make sure they're having their needs met and to, as quickly as we can, repatriate them, for want of a better term, back into our services, as long as that makes sense to do so. Where there are specialist services, with people with very particular needs, we just need to make sure that that's working for that person and their loved ones, and that we've got the best value really for them in terms of the care that's being provided.
Okay, thank you. And any comments about no beds in Medway?
I mean, I guess that's mainly because of the way that our hospital campuses are organised, and that's a bit of an historic thing. And we do know that the economy of scale, both in terms of staffing and creating a hub where we can create really great care. What we do know is having isolated units can be difficult to manage, both in terms of oversight and making sure that they run as effectively and efficiently as they can. We know the CQC take a view about units that are standalone and feel concerned about them, that kind of thing. Now, there's a trade-off, obviously, with the distance that people need to travel into Maidstone and into Dartford and sometimes Canterbury. But in terms of the way we need to make sense of how we provide care, actually having a kind of hospital hub is a really important part of being able to achieve that.
Thank you.
Thank you, Councillor Wiley. Can I just say, Andy, I think, I'm not going to reopen the history of that comment around our wards because, it's clear. I think the question that Councillor Wiley was asking and what I'd like to ask is how many people are out of area at this moment in time? And I think you're saying one, or how many actually patients in Medway and Kent are out of area because there's no beds in Medway at this moment, no beds in Medway or Kent at this moment in time?
As far as I'm aware, we don't have anyone that's actually out of because of that issue. It's not about bed availability, it's about their care needs. That's why they're out of area.
Okay, thank you. Can I ask a little bit about transfer? So it's going to be probably Jackie and you here. I mean, there's a lot said in this report about the bed days lost due to delays, and there was a positive comment made in there about how you both work together to find patients' beds. And so I'm understanding if we haven't got anyone out of area, that relationship's working quite well. But I'd like to know how challenging it is. And maybe I'm going to go to Jackie first, because I know Jackie works on this quite a lot, and there are a lot of lost bed days here. So could you just give me, can you just touch on that, and then maybe Adrian or Andy touch on it as well?
Yeah, thank you. I mean, we don't have the number of patients in mental health beds that perhaps our colleagues in KCC do, and I think in the report it referred to two at the point that the report was written. And actually, I've just had an email from a colleague in KMPT as we're talking today about somebody where there's a delayed transfer asking me if I can give any support. So, I mean, there are challenges, and I think, you know, we know the issues with care homes. You know, we know that's not just the case for KMPT, it's the same for MFT and other hospitals. I think the other challenge for us is obviously when it's younger people. You know, the view is that somebody that comes out of a mental health bed that's under the age of 65, because we class them as younger people in social care, you know, the remit is not to place people into residential care. So we want to look at putting people into a supported living accommodation or something. That takes longer as well because the person has to sign up, have a tenancy. And so, you know, there's a whole raft of reasons why things become delayed. I mean, I know I've said it before, but my frontline teams and my operations managers have a very good relationship with KMPT staff. They're on the phone with each other. And it's very rare that they come to me, I must admit. It's if someone's really stuck that I get involved. So that's always a good thing. But it is difficult. It is really, really difficult at the moment.
Thanks, Jackie. I think for Adrian and Andy, I think for the question for me is around maybe what Councillor Jackson was touching on as well, and Councillor Cook, is about the wraparound care. So obviously, when you're moving people out of hospital, you want to ensure they're not just thrown back in the community without that support. And we do know there is delays in some of that support. So do you find, is it a challenge for the service at the moment to ensure that there is, I'm not just talking about the tenancies, but I'm talking about key worker, counselling, extra support that's needed. Is that a real challenge at this moment in time?
Absolutely. So we started this week with clinically ready for discharge numbers sitting at 63 patients out of a bed stock of 250 beds. And December saw our clinically ready for discharge at 14.5%, which was the highest position for the last 24 months. So it has been a challenge. But we are working very closely with all our colleagues, both multi-agency but also with the voluntary sector as well, to try and wrap around that. We've also put initiatives in place to look at how we manage flow and really identify what we can do to really maximise the use of those beds that we can have.
Thanks, Adrian. I suppose that goes nicely into the safe havens and crisis houses. Just a quick question on that is can you give me an update on the safe haven, the Medway safe haven that opened in August and how it's going? But also the crisis house as well, because evidently we've got that 5-bed provision that opened in October. Is that correct? Are they both operating effectively?
So I will need to check and give you further details on the crisis house, but and which is predominantly led by the ICB. But the co-located safe haven at Medway Maritime is working really well. We're having some really positive feedback with regards to how that's having impact both on our acute colleagues, but also the quality of care for those people who don't actually need to be presenting to emergency departments, but actually need a lower level of intervention that doesn't even need to come to secondary mental health providers. So we can work with our voluntary sectors and other people to help with that. But I'm more than happy to get some further details with regards to the crisis house for you.
And the second one is opening in April. That's not being delayed. Is that correct?
Not that I'm aware, but I will need to check on that for you.
Okay. Just a quick one, Jackie, for you. Do you want to touch? Go on, Jackie.
Just to sort of to talk about another thing that we're looking at working together. So we know that actually we've got 147 Nelson Road that's used to support people with mental health. It's not used in the evenings, so I've been introduced to one of the facilities estate management teams so that we can think about can that building be used in the evenings to support people as well.
I mean, an actual underused resource that could do tremendous work in our community, that is as well. I mean, I just want to talk to you, it's not a difficult question, just about your AMHPs, your practitioners. Can I just ask who supervises them and the team? So from the work they're doing and making independent decisions, where's the supervision? Is it with KMPT or with you guys?
No, so it's with us. So they are, I mean, you can get AMPs in different areas, in different organisations, but the AMPs in Medway Council are managed by us. They sit in adult social care. They are clinically supervised by a senior head of service who's had a lot of experience in that area.
Okay, so Adrian, I think there's just I think a bit of a briefing paper to come back. I think on some of the items that's been mentioned tonight. I mean, it'd be good to get some more information on Councillor Jackson's elements around the autism. It'd be good to see that pyramid if we can get some more information on that. The safe haven, etc. The crisis house would be very good. I just want to finish on the point about the community voice. I think there's something to come back to this committee, and don't worry, Adrian, I'm not going to call you back at the next meeting, so you'll be relieved to know that, and I will make a comment quickly about that in a moment. But what Councillor Shocker mentioned, and others, I think is correct. I think it isn't just all about Health Watch. I think, you know, we're going to be it is quite worrying. You've got enough work on your plate, so I wouldn't expect you to be able to answer everything about engagement. But engagement is a key part of what you need to do with our community. And the comments that Councillor Shocker mentioned about what residents are saying, we could go out in that street now and we'd get the same back to them. And any of us that work in the voluntary sector would definitely hear good things as well as quite a lot of negative things. And it would be good to maybe get something back about your engagement strategy and who you do engage with. And Councillor Prenter asked a really good question around that, and I would hope you was engaged in that Kent and Medway chat process, but if you wasn't, it'd be good to understand why, so it'd be good to get that back. Adrian, can I just thank you? You've come back to every ONS, apart from when you wasn't, when we made you unwell, no joke, when you wasn't well. And I want to thank you for that. I think we know KMPT still has quite a journey to go on. You know we have concerns still around your admissions. I've got to thank you for, and I know this committee will thank you for you've been very transparent when you've come to this committee, and I want to thank you for that. And I know we're going to work with you more. We're waiting for you to give us a green light to visit Ruby Ward when it opens. I know Michael's in process of that with you, but we will wait until it opens and then we're going to come. But I do want to thank you for the way you've engaged with us. I know that's not going to stop, but be prepared to always be called back. But you'll be glad to know we won't call you back for the next meeting, at least the next meeting, so you're okay. But thank you very much for that. If you can get the briefing paper to us, I would really appreciate it.
Absolutely, thank you.
Vice Chair.
I move that we note the report.
Is that seconded? Seconded, okay. Agreed, members? Agreed. Thank you. Thanks very much. Thank you both. Okay, can I ask the members for the GP Access Task Group to come forward, please, to the front table? Okay, welcome members, welcome Logan. I will ask you to introduce yourself in a moment to members. I understand we've got a very short video clip that the members are going to watch first of all from a GP, that's correct? Can we go to the video clip, please?
Student at Kent and Medway Medical School, and I'm also a... Hi. I'm Lois, I'm a second year medical student at Kent and Medway Medical School, and I'm also a Medway Council scholar. And this scholarship has allowed me the freedom to just really get my hands on in the course and to not worry about working full time, especially as a grad. It's given a bit more relief to my family, and it's really allowed me to get stuck into the course, which I'm very, very grateful for. So one thing I like about the course is that the early exposure you get to GP placements and how it's really allowed me to interact with patients and to see clinical manifestations of what we're learning, and it really helps solidify and understand what's actually going on. And it's just really fun, and it kind of humanises the course and seeing the clinical aspects of, it's not just medicine, it's also patient interaction, professionalism, and all the other aspects of being a doctor, which I've been really enjoying, and it's allowed me to consider this career path, which I never thought of before.
Thank you very much. Logan, can I ask you to introduce yourself and your team introduce yourself to members, especially new members, please?
Of course, thank you very much. I am Dr. Logan Manikam, a consultant public health medicine and a locum acute medical doctor at MFT. I'll introduce my colleague Sukh first and then my other two.
Thank you, everyone. So my name's Sukh Singh. I'm the Director of Primary Care for NHS Kent and Medway ICB.
It's on. Hi, Public Health Project Officer.
Okay.
Just press it once. Logan, because your microphone's on, Logan?
Yeah.
No, your one's on, that's it.
Yeah, that's correct. Hi, good evening. I'm Dr. Ash Patient. I'm a GP by background in East Kent, in Thanet. I'm also Deputy Chief Medical Officer for Kent and Medway.
Thank you very much. So, Logan, obviously the report is taken as read, but if you'd like to give us some highlights, that'd be great.
Yes, thank you very much, Councillor. So obviously, as Councillor MacDonald has said, I deem that the report has been read with all actions. Now, first of all, I'd like to make an apology. There are some corrections to be made, which my colleague Sukh Singh will mention. Unfortunately, over the course of Christmas and New Year, I was covering junior doctor strikes and was therefore very busy. And unfortunately, there were some delays in producing the report, so apologies for that. I think the first thing to say is that I just want to provide a bit of context as to where this report sits in the national picture. So I think the first thing is to say that covering MFT over the Christmas and New Year, I've never seen the NHS in such unprecedented pressure. From a circumstance as a secondary care doctor, seeing this picture, I have only empathy for my primary care colleagues because the amount of pressure that we face in secondary care to discharge patients and send them back to primary care to be managed is just unmanageable. So in A&E, I was taking care of patients more than 70 hours waiting in a chair, very poor standards of care, which, to be honest, everyone is doing the best they can, but then the pressure is therefore very much on discharges. And similarly, from a supply side, so this talks about, training new GPs and primary care staff, but amongst many of my colleagues who I've trained with in MFT since 2016, many of them are not actually interested to actually become salaried GPs, largely because the pressures in both secondary care and primary care are insane, and it's very hard on everyone to consider a lifetime career in general practice or in any secondary care provision as it currently stands. Now, I think in context of that, I think it's important to note that this isn't a Medway-specific problem. I'm an MFT doctor for many, many years, but I was curious, to see what the picture was outside of Medway. So over Christmas, or just after Christmas, I did a Boxing Day shift in Hillingdon Hospital covering medical outliers. And for those of you who don't know what medical outliers mean, it's essentially patients who are not on medical wards and end up on surgical wards, even obstetric and gynecology wards, because there's no space on for medical patients in medical beds. I had 53 patients to see over 8 hours on my consultant to discharge, and Hillingdon Hospital is in an area of much more affluence compared to Medway. So the picture is very much the same elsewhere. Now, in that context, our primary care access or GP access task force and its reporting, its findings and our actions is very much a picture of mitigation. We're not here to offer that solution to address all the problems because there is a national picture that is struggling. But for the many people that I spoke to regarding this report and its actions, many of them welcomed it, particularly because they felt that all the things we're doing is very good localized action aimed to address the problem or as much as we can. Now, with that in mind, I'll pass on to my colleague Sukh, who can say a few more words on the corrections.
Right, thank you, Logan. There was just one minor correction, I think, around the safe working limits for practices, which the LMC had recommended. It wasn't, I think the recommendation was the ICB enforces practices around safe working limits. So practices themselves are responsible for their staffing and workforce, so it's not something that we can enforce. But actually then we just wanted to kind of recognise the support that we offer through wellbeing, and we've got Wellbeing Hub that we offer for practices in the context of trying to support them in terms of their work-life balance, because that's much of what we've heard through the engagement. Just a couple of other things I just wanted to add on, just to build us into the context of what we're doing within the ICB. So as many of you know, we're trying to develop our primary care strategy for Kent and Medway, And this report was really helpful in terms of giving us some of that engagement. It was really valuable being part of the group, to engage with stakeholders, to engage with the public, to engage with representative bodies. So there's much of the recommendations that we can also start to put into what we're doing with our strategy work. The other thing I think that was really helpful with this report was around collaborative working. So it wasn't just the ICB or providers doing something, it was collaborative working with the council around many of the recommendations, which was really helpful in terms of what we're doing. Logan also mentioned about, I guess, the pressures that are felt nationally around primary care. So as many people may know, there is a national recovery plan for access to primary care. So some of the things that we're looking at is around how we empower patients. So that's also about self-referral pathways and how we can give patients more control over their own health care. And the other thing we're trying to do is also look at how we build capacity. So some of the recommendations that come through in the reports also support many of that. So one of the areas that we looked at was actually how we can support GPs to become GP trainers, and that was one of the recommendations, how we get more training practices in Kent and Medway, and in Medway specifically. So we've worked with the Deanery recently, and we actually made the process much more streamlined, so hopefully we'll see an upturn in the number of GPs that become GP trainers. But yeah, just generally I kind of wanted to reflect that. I don't know if, Ash, is there anything else that you want to add from your perspective?
Just thank you. And just building on what Suk has been saying is in terms of, we do recognize one very important thing, and I think it just come out in the report which I was reading, is that we do need to build on the trainers, because the future of general practice is the people we produce our own, we basically grow our own workforce. And it's very important that we streamline that. And one of the problems which we were facing, and which was we were getting the feedback from our colleagues, was that they felt the whole process was very cumbersome and was very onerous. And it was thanks to the Deanery who worked with us to make sure that some of the challenges they had to face through the training program, including PG certifications and everything else, is eased off now, so that if I want to become a trainer or any of my colleagues wants to become a trainer, it will be far more easier for them. And we're hoping to use that as a good story to try and get more and more colleagues of ours to become trainers.
Thank you very much. Can I open to members, please? Councillor Printer?
Just following on about your training rollout, it sounds very positive. What's the take-up in Medway? Because you obviously got a number for Kent and Medway, but is it positive in Medway? Are we going to get...
May I come back on that?
Yeah.
I think it's because this has just come through. This is a new development within the last 3-4 weeks' time. So it'll be too early to say what the impact of this would be. But the feedback we had from the engagement which I and Suk did with a lot of the colleagues in Medway and in Kent, one of the challenges we were getting was that, how do you make this easier? We want to be the trainers, but it takes, they were honest. They said, Dr. Ash or Ash, we don't have the headspace to do the whole courses again and again, but we want to support the future of general practice. We want people to train who we can hand over to. So I think we are hoping that once we have made it easier for them, we will get more people to come on board.
Thank you. That's very positive, because the more in Medway, the better. Hopefully they'll stay.
Councillor Wildey.
Thank you. Thank you. I would expect the chairman to remember we had a primary care briefing note on the 11th of March 2021, which basically says exactly the same as every single recommendation that's in this report, so which obviously preceded the report. So as all these things were already in place, the recommendation seems, well, slightly out of place. And as you've talked about GP numbers, the last figures I was given, which was from September last year to the year before, we have lost a small amount of GPs compared to the year before. Now, they are either practice GPs or salaried GPs, which, if we are still losing GPs from Medway, obviously that makes it harder to train new ones. And I'm sorry, but we were told across the country that there's a national problem, which we all know, but Medway does have a considerable less GP to patient ratio than the national average, and Medway is lower than the rest of Kent. So I do find it difficult that we're being told there's a national problem when our problem is worse. It's for the size of our area, we're probably the worst in the country. So in my view, the recommendation should have included that the ICB, CCG, when we started, should have been bringing in and working with the council in all sorts of ways, you know, cheaper rents, houses provided, whatever it took. And if you want to go back further, the CCG and the PCT should not have been so anti-single practice GPs, because, again, that has diminished our GPs, well, by a massive amount. And just to make the point, the people sitting at the top table are well, the same amount actually, than the amount of GPs we saw in total during the length that we did the task group. And going by the titles, there's 2 doctors there, which is the number of Medway GPs we saw, which obviously was not good enough in my view. I know we have
Councillor Wildy, can I just say, you know I'm going to pull you up. You know I'm going to pull you up for a moment because, you know, your points you make before is fine. I'm sure the team will come back on that. But the background is very clear. On pages 33 and 34, the whole background of the task group, right to where we are today, is clear. You know I pull you up on every meeting when I say I'm not going to relive the task group scenario. It's gone to Cabinet, it's been agreed, it's now being processed, and this is where we're getting all the new information from as of now. And it is early days yet, it's early days yet. So if you can we steer away from going back on the task group beginnings if possible, please?
Well, as you know, my view is a minority report went to Cabinet. It still hasn't been finalised at the overview and scrutiny, even with a different chair, different makeup, but it still hasn't come back to scrutiny to be agreed. But
it was agreed at Cabinet, Councillor Wildy, as per other reports that have gone via overview and scrutiny as well. So you won't get a report to go to Cabinet, be agreed, then come back to scrutiny and be agreed again. Cabinet are above us. So
no, I'll finish there. If the chairman's happy to be led by Cabinet, I'm fine. Thank you.
Councillor Wildy, I'm not going to argue about this now. I'm going to pass because, as Logan has said, the team in front of me here worked very hard, have worked extremely hard over the Christmas period, do many hours. They've actually found time to work on this programme, which we really do appreciate. I'm going to say again, it's early days, and I'm sure there's a lot more to be done to make this work. I'm not going to spend your time sitting in front of me arguing with a member about me being led by Cabinet, because you know that isn't the case. We are scrutiny members here and we operate as scrutiny. So, Logan, would you like to lead on the answers to Councillor Wildy, please?
Thank you very much. So, Councillor Wildy, I think in answer to your first question about the relationship of this report to the report done in December 2021, I mean, I wasn't in service covering this at the time, but certainly looking back and comparing it to now, there's certainly a lot more collaborative actions between the ICB and Medway Council, particularly on communications, adult literacy, a lot of new channels of communication which we took for granted and certainly has definitely strengthened what we, this GP Access report. Suk, I'll let to you.
And just, I guess, I wanted to pick up on the GP challenges that we've got in Medway. So I don't think it's a case that we don't ignore that. I know it's not in this report, but we have the GP attraction programme that we have been running that has been working with Medway Council, looking at the challenges that exist in terms of housing, schools, education, and how we can get people to come and work in Medway and stay in Medway in a GP profession. And Ash, I know one of the areas was also Thanet, so Ash, you might be able to kind of explain your experience as a GP looking to bring GPs into that. The other thing I was going to raise is that we also have a Tier 2 visa programme, so we're just seeing what we can do to encourage more people to come and work within our health and care system within Kent and Medway, and also just focusing on areas where there are particularly low numbers, such as Medway, and how we can get people to come and work here.
Thank you. I'm going to answer on two parts on that. The first part is with regards to what Sukh was saying. I'm from Thanet. We at one time had the 4th worst GP to patient ratio. But it was also important for us to, at the same time, because we knew there was no cavalry over the horizon. So whatever we had to do it ourselves. And some of those things were, like Sukh just mentioned, about having the GP attraction package, trying to get the GPs to come into our areas, offering them chances and opportunities to be able to come settle, and giving them sort of an environment where they would actually flourish. That's very important, of which one thing I've realized. I started off in a practice with 2 GPs. Today we have 7. So if we build an atmosphere around us in which we're welcoming and we're able to nourish them, people tend to stay on, and that's very critical. And I think from the GP attraction package, from some of my neighboring practices who have been able to attract people there, most of those GPs who have come in have stayed on. So it's definitely working. It's a work in progress. I think we need to keep building on that, and that's very critical. And we need to do the same thing here in every other part of Kent as we go forward. So that's the first thing. The second thing is, and this is me talking as a GP now, it's not about just, when I did my training in 2010, at that time one of those things was that most of the patients used to come and see the GPs because we used to deal with most of the things. But the bottom line is, I'm not the best person to deal with everything. For example, somebody comes with a mental health problem. Somebody comes with a pharmacy-related problem. Somebody comes with a physio-related problem. I have now colleagues or a plethora of colleagues who work with me side by side. Now, if you look at that ratio, we are actually not that bad. In fact, when I was looking at the last data, we have almost 45 GPs to every 10,000 patients, but we have 37 of the direct patient care facing colleagues, like means the physios and others. In fact, that's better than Surrey, which has one of the highest GPs to patient ratio. So the times have changed. The way we deliver care in primary care is changing. And that's very critical to recognize as we go forward. And so it's basically not just the GPs, but the multidisciplinary team which we build around those GPs, and so that we can deliver that more effective care to our patients than we used to do sometimes back.
Thank you very much. James, did you want to come back up before give Councillor Wiley a chance to come back?
Thanks, Chair. And I think Dr. Pesha just sort of fleshed out some of the points I was going to make. It is about creating the environment. If members that you may not have recognised, but the GP trainee, or the medical trainee at the moment, is one of the 3 scholarships that this authority has actually provided to fill the breach, because quite clearly this issue has not just happened overnight. And, you know, I'll say, Josh, Clinical Leader National of the Year, that's Dr. Pesha in 2021. He does understand, I think, the context of providing people within an environment. And if you go back to the video, I know it was short, but what that medic was saying was, it is about going out and have a positive experience. We as an authority are a training location for GP trainees who come through, so we try and provide them with the opportunity to engage with all of our services. We had a great debate already with Jackie's points around, 70-odd bed care home, the facilities that we need to put in place in order to move a little bit upstream. So the GP role, as I said in that, may be quite pivotal, but actually there's a broader team in primary care that will provide support. So I think looking at the action plan, I think we all recognise that there is more work for us to do, and I think you can hear that from the colleagues that are actually at the front end of that. But I would recognise as well that we've got to just remember access is just one thing, one bit of the jig. So you can get good access, but is the quality of the support, as the clinician of the year would tell you, it's got to be the right thing delivered by the right person. That's all I'd like to say, Chair. Thank you.
Councillor Wiley, did you want to come back? Were you okay?
Well, just 2 quick things, because This isn't a question about GPs, but our GPs do have very different ratios, the different practices to their patients. Are the nurses, etc., that we are getting, where we have the least amount of GPs per ratio, the rural areas, are they getting the most number of nurses and the other professionals?
So, I mean, I'll throw to our primary care director, but what I would say is part of our transformation programme is to look at how those teams work. And we've got, I'll throw to Sue, because we've got integrated neighbourhood teams that are trying to actually deliver a different way of providing that kind of support. And you're quite right to flesh out that in our rural areas, the challenges are slightly different. We need to have a skill mix that will meet those particular requirements. But again, we talk about nurses, but the primary care team is quite broad, and having nurses in that space is also important. But you've got other allied health professionals that also do those jobs. But I'll throw it to the primary care director. I'm sure he'll be able to come.
Can I just keep that brief though, because I do want to keep on to the GP task group and the topic at hand. So if you're going to answer briefly, I only want it a brief answer on the nurses because we're talking about GPs here today. Councillor Whitey, Watson.
Yes, we're talking about the recommendations, aren't we? Yes. So, and that is to bring in nurses and the other professionals. Yes. So in those rural areas, are we filling the roles of nurses that we need as easily as we are in the more built-up areas? And can you explain why we are still losing GPs overall, you know, if we are trying to bring in more?
May I come back on that? Two parts to your answers. The first part is, Councillor Whiteley, is we in Thanet, still, I'm just going to give you an example from Thanet because that's what the example I gave you earlier. We still might be red on GP to patient ratio, but we're actually green when it comes to overall advanced healthcare practitioners plus GPs to patient ratio. So that tells you a lot that it's the times or the way we deliver care is changing. So that's the first question. And the second question is, you would have heard in the news nowadays is actually there is something changing on the ground. One of those things which is changing is we slowly are getting more and more GPs coming into the system. Has that hit on the ground at present? I can say the ratio is changing, I would say no, but it feels slightly there is shift on the ground. But it might be another 6 months to a year, but when we actually start noticing whether that shift is actually tangible and sustainable or not. So answer to your question is yes, we are green on overall workforce. Purely GP to patient ratio, I think we're still in the red.
I'm going to move on a moment now, Councillor Whiteley. Well, I'm going to come back to you in a moment. I've got another 6 in front of you.
Because it is specific to that answer.
Well, if you come briefly, then I'm moving.
It is. You was talking about Thanet. Do you know our rural areas, the Medway rural areas? Do you have those figures?
I don't have them to hand, but I think we can get them to you. So I think Ash was saying we can do the direct patient care, we can do the GP numbers. Just to explain a bit of context on it, practices receive a global sum per patient. They will then recruit their workforce based on the funding that they get. So quite often, as Ash has done, where you have a lower number of GPs available to you, you will supplement that with a wider workforce. One of the things that we want to do as an ICB is work with all our practices around workforce planning, so they can actually develop active workforce planning, looking at the stuff that James mentioned about working with integrated neighbourhood teams and making sure that they've got the right complement of staff, clinical staff, non-patient facing staff, direct patient facing staff to meet the needs of the patient's population.
Thank you. No, thank you.
Thank you, Councillor Whiteley. Councillor Campbell.
Thank you, Dan. Thank you, first of all, Logan, for your absolute candor. That was interesting to hear. This is something that keeps me awake at night, what's going to happen to GP access and the NHS, because I've got 2 kids, and I often wonder what they're going to grow up to be and how it's going to affect them. And absolutely the first query I received when I got elected was about GP access, was about can you do anything about it? What can you do, because it is so... This is definitely the defining issue of our times, I think. So there's so much work happening to to move people away from just going to the GP, as I understand it, to kind of go laterally to different services and accept that, and so much reliance on technology as well to make that happen. I just feel like the culture still is for people to expect to see a GP. So predominantly, most of the time when people talk to me, it's like, oh, well, can't call the GP and we were fobbed off. That kind of language is what we hear. So, I mean, there is something about the culture, and even people who are digitally active for their health and for their family's health, I think they seek reassurance in seeing a GP face-to-face rather than other services. So I'm curious, how effective are you being in shifting that culture? Because I'm not a Luddite. I'm not saying we should be stuck in the past, but this is a cultural issue, isn't it? Of course, we need to access and harness all the technology we have. There's also obviously all the people who are digitally inactive. For them, this is just a world that's beyond them. And something as critical as, feeling really vulnerable in illness, they just feel completely, alienated. So I just want to know what's the future? What do you see? How do you see this culture being shifted? Thank you.
Some of the things that we have done, so we've been looking, I guess, building confidence and trust around the wider healthcare team, so it isn't just about your GP. So we've done some really good stuff around social media just to explain about different roles in general practice, how they can help and support you. When we've been doing our strategy work and engagement, one of the things that we did hear from people was to say, actually, I don't know where to go for my first kind of contact. I will always go to my GP because that's my first point of contact. One of the things that we, I think, need to get better as a system is actually helping people navigate to the right place. You can do the kind of advertising campaigns about stop, think, choose, but actually that first point of contact really needs to help people navigate their way through. It isn't just all about going to 111 either, because that can get overloaded and there's real difficulties around just trying to find your way through that pathway. But one thing that I think we've recognised when we're developing our strategy is actually how can we help people navigate their way through the system. So there's some of that, and there's also, as I said before, it's about building confidence and trust in wider healthcare professionals and people to know what they do. So we can give a title, but actually what's that person able to do? What is a pharmacist working in a primary care network able to support someone with? It isn't just about prescribing, but it's about medication reviews, it's about long-term condition management. So it's a lot of that. But Ashti, do you want to come in as well?
And just building on what Sukh was saying, and I completely recognize where you're coming from, because a lot of my friends and my neighbors say a lot of things what you just said. So I do appreciate that. I think there are twofold things which we have to do in terms of being able to target that. And on the first fold is 3 answers for that. That's communications, communications, and communications. We need to get better at that. We need to be able to land the message right. Because if my population is not getting it, that means the fault lies with me, not with my population. I'm not getting the message across. So we really need to work on that. That's the first aspect. Second aspect is what do we do internally to make the system easier for them? I want my patients to be able to understand where they have to go, but I don't expect them all the time to know. So I need to train my nurses or my reception staff to be healthcare navigators, to be able to help me navigate my patients to the right clinicians all the time. That's the first thing. And second is the digital platforms which we use have to be far more user-friendly than they currently are. So we haven't got things right still, but we're working on them, and we're training so we have got programs ongoing in which we are doing healthcare navigation training for our reception staff. It's going to be an iterative process. It's not something which is going to happen overnight, but we need to keep working on that. And simultaneously, as I said, the first thing, we need to get our communications absolutely spot on, and we might need your help on that as we go forward.
Thank you very much. Can I just say to members, I've got 6 people on the list here and I'm running out of time. So if we can keep the questions very direct and we can keep the answers direct as well, that'd be really good. So, okay, Councillor Mark Brenner.
Thank you. I welcome the report, and so much so that the local government committee has circulated this report as good practice, so I'm comfortable to know that we're doing the right thing with this going forward. My point is on 4.5 in our report is the relationship of pharmacies, because obviously a lot of these recommendations is the long term, and getting GPs up is a long-term goal. However, the pharmacy could take a lot of work out of the GP. I myself have gone to the doctors for lots of things where I thought actually I could just go to the GP. Dealing with a relative who we suspected urinary tract infection, phoned the doctors, so we got no appointments, got no one to test your dip test. If you go to a pharmacy, they might be able to do it. I couldn't find one online. Went through 101. It wasn't they said there's no one in your area that does that. They just had no knowledge. So are we bridging that gap from what a pharmacy can do and what through the GP signposting patients to go to them pharmacies to free up the GP time? Thank you.
Yeah, so there's going to be a pharmacy, what they call Pharmacy First, which is going to be launched nationally. So that's where community pharmacy can support patients with 7 common health conditions such as sinusitis, sore throat, earache, infected insect bites, impetigo, shingles, and uncomplicated urinary tract infections. So I think, but again, one of the things that we're going to have to do is communications, just to make it really clear about what community pharmacy can support patients with. So, and again, similar kind of challenges, how do we make sure we get that message out? And again, we could work really well with the council about how we make sure that people are aware of those services. But there's definitely a good opportunity with that. And I've also been working quite closely with the pharmacy committee as well about understanding, I guess, how we can support them. Because obviously that means there's a change in their shift of their workload. There's stuff that they're going to have to do in delivering clinical services. So we need to make sure we support the community pharmacy community as well.
Yeah, and will that Pharmacy First, will that feed through to 101 and the wider picture as well? So it's all linked as well, not just locally, community-wise?
Yeah, so there'll be pathways through 111 and through GP practices into that service as well, yeah.
Thanks, Mark. Councillor Cook.
Yeah, thank you very much. I agree, it was a really positive report, really exciting to see that efficiency and focus on doing things really well in the boundaries that we're working in. Just sort of testing some assumptions and things I've heard here, I believe that it's very more common in the southeast that people don't go to their GP and leave things and go to A&E, and then they're more sick than they were, and that it's more expensive for somebody to be seen at A&E than it is to be seen by their GP. And so I'm really interested in that kind of efficiency of our money, not necessarily Medway Council's money, but the money that's being spent on healthcare in the southeast. And what I'm interested to hear, you've talked about lobbying in number 14 about, to the government and that pressure. Is that the case? Is money kind of being wasted by people not going to GPs and going to A&E? And if that is the case, what can be done about that? Is there things that can be done at this level? Can we support that at another level ourselves? Thank you, Chair.
Thank you.
Thank you, Councillor. So just very briefly from my own experiences. So in the second wave of the junior doctor strike, I covered just under 70 hours over 6 days in the acute medical take, so I saw effectively half of the take. I can say with reasonable confidence that everyone who attended A&E that we saw in acute medicine definitely needed to be there. I don't think anyone wants to spend 12 or 15 hours in A&E without being seriously unwell. And actually, to be honest, I think there are clear pathways now. So for example, one of my colleagues commissioned a flow walker in front of the ED waiting room that signposts people to other VCSEs and other services. So from a personal experience, I can say that, I think A&E is being used appropriately in MFT.
Is that okay, Councillor Cook?
If I just come back on that, is there a funding issue where funding's being put more into hospital route that it could be more effectively used in a GP route, or is it two different pathways?
Yeah, so obviously someone that goes into A&E is going to cost more money than someone that's been seen in general practice. I guess what we have a challenge with is it's that demand and capacity and how we kind of bridge that gap. And there's also behaviours, and also, like you're saying, if someone just wants to be seen, they're going to go somewhere where they know they're going to be seen. And quite often that might be an urgent treatment centre or an emergency department. So there's stuff that we can look at in terms of understanding why that happens, why people are having to go through that route. But I think the problem we've got to resolve is actually just how we can effectively manage the demand that's coming in. And so looking at, I guess, all these kind of options and solutions will help us try to bridge that gap.
Thank you. Is that okay, Councillor?
Just to top that up, in Medway we have an urgent treatment centre which front ends the ED department, and it's very, very good. I have used that, so I know that it's a very good urgent treatment center. So most of the activity which would normally have ended up in ED department is actually managed and supported within that UTC.
Thank you, Councillor Shocker.
Yeah, thank you, Dan. So yeah, I want to say thank you for the report. I'm still kind of lost to why certain people are crying over it, but actually, from my perspective, our administrations were knocking on thousands and thousands of doors before May, and this was continuously on the doorstep. People were crying about this. And for me, as a new councillor, I wasn't sure what we could do as a council to address this. And I want to thank the Cabinet for bringing this forward, because something we can go back tangible with this now, with the collaboration actions, the scholarships, and the positivity I feel around this. I know this is at an early stage, and there's lots still to do, but yeah, we're going to resolve the issues. And honestly, for a lot of the residents, they know what the core problem is. It's a sledgehammer that's been taken to the NHS by the Tory government. Yeah, so I'm just going to get that out there.
Thanks, Councillor Shoker. Councillor Brake.
Thank you very much, Chairman. Most of the points that I wanted to raise have been raised in questions, and I think that I've had most of the questions, but a couple of points I'd just like to make, if I may, please. And that is the importance of resolving and solving this problem of GPs, particularly here in Medway. And I say Medway because that's what we're here about. This is our bread and butter. We are here to represent the people of Medway. And it is important, and thank you for the work that you have been doing, and we sincerely hope that this is going to continue until we are back on track. It is so important that the impact of not having the GPs in place can be seen in the A&E waiting department at Medway Hospital. And that is simply, and this actually came out of the public board meeting that was held yesterday, that it was actually made clear that we have people who are coming to the hospital simply because they can't go anywhere else. They've tried on the phones, they've tried to see a GP, they've tried all the telephone numbers that are available to them, and they're not getting the satisfaction. So their point of call is to go to the hospital. End result is we have lots and lots of people sitting there waiting to be seen, to be processed, to be triaged, to make sure that, and really in many cases, to give these people confidence that things are not so bad that they need to be in a hospital. So I think this is very important. Now, James Williams, our Director of Public Health, he also made mention of the training and the opportunities that Medway Council, through its public health programme, has given to 3 young people that to train in medicine. And I'm pleased to say that during my tenure as the portfolio holder, that is something that we were able to do. And having spoken with 2 out of the 3 young people who took up that opportunity of that scholarship, they are determined that when they are finished, they want to go into GP practice. That was clear at the very beginning when they were interviewed, but nothing had changed when they were spoken to a couple of years later. They are into those programs. That is what they want to do. And because they are Medway people, their expectation is they're going to be able to come back into the Medway towns and practice here. So when we embarked on this programme, and James will confirm this, everybody across Kent, they all thought we were crazy. What are you doing, why are you investing money in these people when there's other people around to do this work? Well, it's become now very clear. We have the foresight to realise that we had to look after people of Medway. And I still encourage other authorities across Kent and in fact other parts of the country. If you want to get your GPs, you've got to go out there and you've got to help, you've got to support, you've got to do everything we possibly can to make it happen. So I'm going to leave it at that, Dan. I've just said my piece, but I think I've had the answers to the questions that I wanted to raise. Thank you.
Thank you, Councillor Bray. Can I go to Councillor Llewellyn-Printer?
Thank you for letting me back in, Chair. Because I was overzealous and excited about the training rolling out. I didn't mention the student on the video and how positive she was about her GP rotation and the experience she had. And so that was good. And also to say, Councillor Wilder, your concerns about the number of GPs. I've heard recently about a new GP who came because of the attraction package and it was very positive, and she's enjoyed her time here in Rochester and has decided to stay. So that's a good example of how it's working. So we just need to see more cases like that. So thank you very much.
Thank you, Councillor Prenter. Councillor Jackson.
Thank you, Chair. I'd just like, it's really, really quick, and I've made this point before, so I'll just make it really quick. But thank you so much for your report. It's really inspiring. I work in GP practices every day, and to see the work you're doing is really encouraging, and the enthusiasm is really good. But looking at the report, the digital inclusion, one of the things that we do in working with the surgeries I do is get the PPGs involved with the digital training, because it's so much more better for the patients to be taught by their peers on of an age that they then feel confident. If they're over 70, they see somebody else using the digital, whether it's the app or the website for the GP surgery about how they can book stuff. It gives them, and then it might build a bigger community and gets the GP back in the heart of the community. So that's what I want to say. Wonderful work. Keep doing what you're doing. Thank you.
Thanks, Councillor Jackson. Councillor Wilde, is it a question? I'm bringing you back in at the end.
Let's say yes. I would just like to, my memory of the numbers, since 2017 and 2020, we lost 21 GPs. Since then, we've lost, and these are practice GPs, not consultants, not locums. These are our salaried GPs, as we all know GPs. 21 were lost in those 3 years. And the few I spoke to or knew, it was to do with the way CCG were disrespecting them as single practice GPs. Since then, we've lost 1 or 2 per year, and this is full-time equivalent, because we all know there's a difference. And as political points have been made, I think Councillor Shocker did show exactly why some people don't think that this scrutiny is being run separate to the Cabinet. But
Councillor Wilde, thank you. Councillor Wilde, thank you very much for your time. So let me make something very clear here. Thank you very much for your time here. I think when the question is being asked, I think what Councillor Campbell said around the trust, you remember the GPs were always the most trusted people. And I think it's all about communication here. I think if you could get the communication spot on, and I know that's what the GP task group, the access group is aiming to do. It's all about that communication route. I can honestly say in my casework, a lot of it is around they can't get through to their GP, like Councillor Campbell was saying. A lot of people don't like the technology, having to do the app and everything else, but that is the way we are moving forward. But I think we need to tell people why we're moving forward, and it isn't just a way of cutting costs, because that's what I think the public feel and they start to distrust. And I think if we can get the communication right, we'll be there. I also think what Mark Prenter, the comment he made about pharmacies is critical. James knows I go on about pharmacies all the time, and I think they could be doing a hell of a lot more in our community and should be allowed to do more. Many of them want to, but should be allowed to do more in our community, prescribing, helping public health, doing everything to try and ease the pressure in secondary care as well as in primary care. However, it is good news, Councillor Wildey. It is good news. It is no good this committee sitting here. It's no good members thinking that we're in Cabinet's pocket when I will move on to my next agenda item, and I think the members are waiting to go into that, and it will become very clear how we challenge on this committee very effectively. You may not think so, but we are the new administration, and that's the way we work. But we are not going to sit here and be negative when we are seeing improvement. We will be calling you back, and you know I will bring you in, Logan, don't worry, because I'm going to ask you a magic question in a moment. But we will be calling you back, and Councillor Wildey, you held me to account and said to me you wanted this to be called back to CAP 2 ONS on a regular basis, which I'm doing. And actually, we've called it back early because we've made these improvements now, and I'm hoping in 6 months' time or a year's time, it's going to be so much better. And probably because maybe there might be some more investment from it on a national basis. However, I'd like to thank you, but I'm going to ask you, Logan, and I can ask the clinical lead of the year as well, maybe the ICB, if you had a magic wand, what would make this better now in Medway with regards to our GP recruitment? Because we hear that people don't want to move into GP recruitment because of the pressures. Now, money doesn't necessarily going to change that. Having money for rental or having money for, it doesn't necessarily mean they're going to be encouraged to go in. Logan, you started this evening by saying the pressures that you saw over the Christmas period, etc., and how people tell you they don't want to go into it necessarily. What would be the magic wand?
So I think coming back on the point that quite a few have made in terms of GP numbers and GP access, but really in truth, this should be called a primary care access task force. So there's a lot of questions being raised about patient ratios to GPs, but similar questions are not raised as to the number of secondary care doctors to patients. And the reason is we actually do work in teams. So for example, and I'm giving you worked examples in A&E, when I had patients with heart failure, and that's obviously a severe medical condition, we discharged them to community heart failure nurses. We do not put in our follow-up plans for GPs to follow them up because actually they're not the best people to follow them up. Same for tissue viability nurses, community respiratory nurses. We get our allied health professionals to actually step up. Even for high blood pressure, the referral pathway is back ideally to a pharmacist. We don't, do that. So I think the magic one might be a culture shift or a mindset and communication, same as my colleague mentioned, and also being very clear, of course, as to telling our patients where we see them, those pathways, and education of our frontline staff of those pathways obviously helps. And I'll pass it to my clinical colleague to answer the second bit.
Thank you. I think there will be two things I would ask of if I had a magic wand, and it would be a humble request actually, more than anything else, Chairperson, is that we really need to work together. We really need to work together. For example, estates. Why do we have different estates? We have estates, you have estates. We sometimes struggle with estates. We would love to use some of your estates to work with you. We would love to work with some of your staff. How do we maximize whatever resources we have? It's not always about financial resources. It's about human resources, about every other assets which we have, every public asset we have. Let's sweat it together and let's make it better. So I think that will be my humble request. And the second is communications. I think my colleague just mentioned that. Communications. Let's do it together. Let's send a message out to the public that we are all working together, we're making things work. And if that we sometimes we don't get it right, pull us up on that. But more importantly, work with us and in getting the message across to our patients and our population.
So did you want to come in with anything about Magic Wand with the ICB? Or,
Yeah, if I had a magic wand, I'd have sorted this out. But I think when I speak to GPs and people working in primary care, I think that the biggest challenge is just generally it's workload. And I think actually what we want to do from the patient perspective would also make an impact on what that workload is going to be for a GP perspective. And I think that has a real positive impact in people wanting to stay in, working in general practice. And also, I guess it's actually feeling valued. So sometimes, quite often, because it's so difficult sometimes to get a hold of a GP, sometimes that reputation and that feeling valued by your community is really important to them. So I think there's a couple of things. One is actually if we can address the workload issues, that would help in terms of helping us to retain GPs within Medway.
Thank you very much. I'm sure we can feed back via our minutes to Cabinet, etc. And Logan, you can probably feed back into your next steering group about the change of title and your change of to bring a wider aspect into this would be easy. But can I just thank Tala? Can I thank everything you're doing as well? Because I know I didn't put you on the spot, so don't worry. And Suk as well, but also, before I hand over to Rick, can I also thank Logan and Dr. Peshan for your time and for what you do for our community. The majority of this committee really thank you for what you do. Vice Chair.
Yeah, I move that we note the updates and progress achieved in implementing the recommendations from the GP Access in Medway Task Group report of June 2023.
Thank you, Vice Chair. Is that seconded? Seconded, Councillor Britner? And is that agreed by members? Agreed. Thank you. Thank you very much. Thank you for your time. Members, we're going to take a 2-minute break while the ICB colleagues come to the front, please. Thank you. Members, we are now on item 7, is the Kent and Medway Integrated Care Board Community Services Transformation Update. Can I ask, Mark, can I ask you and Ivor to introduce yourself and also other members up on the front table, please?
Do you want me? Oh, hello, I'm Jane Black. I'm the Chief Exec for Medway FT.
Evening, Martin Riley, Managing Director for Medway Community Healthcare and also the Senior Responsible Officer for the Health and Care Partnership.
Mark Atkinson, Director of Operational Planning and System-Wide Commissioning for the ICB.
And Ivor Duffy, Chief Finance Officer of the ICB.
Thank you very much. And also we've got Councillor Theresa Murray, also as part of the panel as well. Can I just quickly some background for members? Those of you who remember, on those that you weren't here on the December ONS, I required or requested after our last paper from Mark and the ICB and Ivor, I requested to have people come back to this meeting. The people I also requested wasn't just the ICB, it was also Martin from MCH, Jane from the hospital, and also Councillor Murray. Can I remind members, I'm going to go to Mark, and I'm going to ask Mark to just give us some highlights of the differences of the paper, to add anything you'd wish to add. I'm then going to ask the other 3 members 2 questions to answer for the panel, but then I want members, when they're asking questions, to remember we're here to talk about this procurement process. Jane was already here, Councillor Murray's already been here, and MCH are here our next meeting. So I don't want to focus on that service. We are focusing on the procurement this evening, if that's okay. And it's good for the members. I'm only going to ask you the same 2 questions. Okay. Mark, over to you. Just give us a quick highlight, please.
Thank you very much. So the paper before you was written after the concerns that were raised in the December HASC, and I've had a number of contributions to the paper, both from Martin and from Jane. I think the ask for the ICB was to come back with more detail around the sort of the transformation and the model of care. So I've attempted to do that in the paper, and it really focuses on the 11 transformation aims which were in the original prospectus. As we all recognise, the Medway community services play a vital role and an integral part to the health and care in Medway, and they deliver high quality services. But we do aim to address some of the variation in inequalities in terms of access to service and delivery, and reduce some of the health inequalities we've seen, not just in Medway. This isn't just about Medway, this is about the Kent and Medway approach. So we want to reduce some of that duplication, fragmentation, and that lack of consistency. And we recognise there's some inefficiencies in some of those services that we have across Kent and Medway. What we'd like to get to is a position where our services are not complex to navigate. It's easy for patients, clinicians, and clients to find access to services. I think the big difference in the paper is that we recognise that community services need to be developed through local engagement with the support of the HCPs, working seamlessly across the councils, primary care, mental health, acute services and the voluntary sector, with the patient or the client at the centre. So what we plan to do is to kick off the engagement with a series of workshops and surveys, including patients, carers, involving Health Watch and the professionals, and obviously the council members will be part of that engagement piece. And we recognise that the HCPs are well placed to help and support us with that piece of work. And that's the big difference in the paper, because we were planning to do that during that 10-year period, where we've had to extend the contracts up until September 2025. It's given us a shorter window of opportunity to undertake some of those transformational aims. We will also use some of the work which was undertaken from the ICS and the insights, ideas and barriers of Kent and Medway people. So we've got a good paper which helps and supports and guides us in some of those ideas and views from patients. I've included what are the 4 transitional aims. So greater engagement, a reduction in contractual boundaries, embedding partnership and shared responsibilities, and a greater focus on prevention and early detection. And then I've also included what will be, I think, the next steps, but we'll probably need to have that discussion here. So further co-design of the model of care, taking an asset-based approach, sharing the best practice, developing the workforce, the cultures and the capabilities, and developing the relationships between the providers. And then the last thing that I'll just cover, Chair, if that's okay. So I have included the 11 transformation ambitions, and that was taken from the prospectus, which I think we would share with you previously, but I think this paper now supersedes that. All of the information that was in that prospectus has been transferred into this paper. From what I remember of the December HASC, there was a challenge put to us we need more detail. We need to be able to see and measure the transformational aim. So I've attempted to include how you might see that we've made that change, the changes that happen. They should be tangible, they should be measurable. We've also included a lot of the references to NHS England's best practice effectively. These are all of the things that we as the NHS should be doing in the next 4 to 5 years. And I've included what I think are some key milestones. That's probably all that I wanted to say, but I'm sure that Jane and Martin will want to build on that as well.
Thank you, Mark. Just two quick confirmations. One, obviously, that was the vision that you were stating at the December meeting is what the ICB's 11 ambitions are. That's your vision, just to make sure we're clear on that. Okay. And did you want to mention anything more, being more Medway specific around services?
I'm not sure I necessarily need to. I mean, there is going to be, as I've said, we'll work with the HCPs. So I think that's a change that we recognise. That was one of the criticisms that we had from both the HASC and the HOSC, was that engagement. So we need to work with the HCPs. We need to work with Martin's team, Jane's team, to really make sure that any of those services that we develop and transform are done in or co-designed with Medway patients and Medway staff.
Thanks, Mark. Jane, if I go with you first, is that okay? So the first question, so they're not. So if you can, other members can remember, because it might change as I go along. But the first question is, how confident are you with the delivery of this procurement and transformation plan in the timescales that are listed in this paper? How confident are you of that? That's the first question. And the second question, if you wanted to take it, Jane, the second question is do you think it would significantly improve Medway, or could it possibly end up with us losing services?
Thanks, Chair. Am I confident about the delivery of the transformation plan? I think one of the important pieces, and having worked with Martin and the Health and Care Partnership and now alongside with the ICB, looking at what that could look like, I think it's really important that actually we do this. If we don't do this at the moment, you've heard some of the issues, particularly for Medway Foundation Trust, and the number of patients that we see that have to stay with us because we don't have the right services out in the community, or they're not as slick or as good as we could be. And so there's a number of things. I think there's an opportunity to redesign it. Our population in Medway is changing, and it's going to change over the next number of years. We're building new houses. Our population, particularly the elderly population, is going to significantly increase. And therefore, we need to respond to those things. I was sitting listening to, around the GPs and talking about, the ability to be able to have that connection with primary care so that patients don't have to come into us, but actually could go directly to a place and have support in a different way, which is far better than sitting in my ED for 12 or 24 hours, because that's what some people are doing at the moment. The bit for me is that, so the confidence around the delivery, I think the important bit around that and the confidence is that we are involved with that. We have the opportunity to redesign those services, and I'm confident that will allow us to be able to do that. We already know through the work through the Health and Care Partnership, what some of those services need to be redesigned to, and how it could look differently and how that would improve the outcomes for our patients. So I suppose from my point of view, if we don't do this, you know, even going to 2025 in September is a long way off. And actually, we need to start doing some of this now, which is really important. So to answer your second question, will it improve the care for Medway patients? I think it will. At the moment, we've got 30 pathways for discharge at the moment around for going out from us in particular. That's far too many. We need to streamline it. We need to utilise the workforce really well. There's opportunities there for different roles and different professions to really come together. And I'm confident that if we do that, particularly through the Health and Care Partnership, working with Martin and the team, we can produce something that actually will meet the needs of the patients that we're not meeting at the moment.
In this vision that's set out in this transformation plan in the timescales, Jane?
We've got to put that vision together. I think that's the piece that we have got the opportunity to actually redesign it. And I think...
But you're confident in the timescales that are set out in the paper that you'll be able to do that?
I think we can do it. I think we already know, and I'm looking at my partner in crime, I suppose, here, is that we already know what some of those services could look like, what they should look like. And I think having the ability to be able to get on and do that is really important. Waiting another year and a half to then start that work is you know, I think we need to do it now.
Thanks, Jane. Martin.
So as the incumbent provider, you'd probably expect me to give a slightly different answer to that. So trying to give a balanced answer to those questions. I suppose the timescale is ambitious, but again, what I say to the timescale is actually we need to do it now. Some of the delays in the procurement has not been helpful because it stopped us actually progressing. So regardless of procurement or not, my personal view is you don't always need a procurement to achieve these things. There's other ways of doing so. So the work we're doing as partners, Health and Care Partnership, which we're all together partners in, we can do some of this now. Procurement can be positive and it can drive improvements and efficiencies, but that's not always the case. So on to the second question, it can be unsettling for staff. Along with the discussions we had on primary care and GPs, community nursing is another national issue in terms of recruitment. So again, looking at the age profile, there's consequences of going through certain processes. My view on both of this is actually not to wait for the procurement. As Jane has alluded to, there's a lot of work ongoing. I think the change in the paper is positive in terms of engaging the Health and Care Partnership. We've done a lot of work on population health, so we know the criteria and the areas for us is respiratory, cardiovascular, frailty. And again, in the paper, sort of, and I know Mark's not set on this, or the ICB's not set on this, there's around 11 criteria in the top 4. Going back to the previous conversation on primary care, we're going ahead with integrated neighbourhood teams, which is looking at community nursing, respiratory teams. We're doing that already. So there's a couple of the areas in this paper that actually we're progressing on with as partners. So how the geriatricians come out from the acute, so have a frailty module around neighbourhoods. So there's a lot of that work that actually has to be done now. So going back to the timescale question, actually, it's not about waiting until September 25 or not taking the foot off the accelerator. We need to do that. And again, I suppose the devil's in the detail when we've got specifications, but at this moment it's hard to comment without seeing a cost envelope, seeing what's included, what's the specifications and all those aspects. So I think over time, working together as partners across the health system, that's what we need to do to make sure we get the detail and we get the appropriate level of service, what's required for Medway and Swell from the Health and Care Partnership hat. And it's the demography of this local population that any specification needs to address. We need to address the services required for this area.
Thanks, Mine. Could you pass the microphone down to Teresa, please? Councillor Murray.
Yeah, thank you, and thanks for inviting me this evening. And I've really appreciated, before I answer the questions, the work that Scrutiny has done on this, including Kent members, because these services are absolutely critical to the health of our population, and we can't get them wrong. If I turn to the report and my confidence about it, Dan, I think parts of the report are very honest, that where it details the frustration that people express with access and the complexity of understanding what's available. That's something that needs to be definitely reviewed. And I think it's been really useful today, just by coincidence, to have the GP access report before, because, as Jane has said, some of the things there, particularly that Logan identified, the way that people are discharged and where they're discharged to, shows how important that partnership working is, and actually how the interdependency of the services are really important. So if that is a recognition, then I would be confident that the redesign can work. And I think that the kind of the redesign is more important than anything to do with procurement. There do need to be service levels agreement, absolutely there do. And Martin's organisation and others need to have confidence that they know what's expected of them and that they can meet the demand. The report identifies duplication, and I appreciated all the background reading detail. I think that was useful, actually, because we do need reminding what the expectations are of the NHS on our local services. And if I just give an example, you talk about speech and language bits showing there's a lot of duplication, but the report hasn't got any quantitative data in it. So I can't see from that report whether the fact that duplication has been identified, and presumably there's going to be some kind of realignment. Well, is the fact that there's duplication now related to being able to see more people more quickly if the services were aligned? Or is the duplication a positive thing because it means that in the round more people are able to be seen and the waiting times are shorter? I can't get that from the report, which brings me to the fact that those kinds of things make me wonder about the timescales. The other thing that kind of inhibits my confidence about this is the number of boards that are mentioned. There does seem to be, I count 7. I know some of them exist already. So we've got the Elective Care Board, the Ageing Well Board, the Diagnostic Board, the Urgent Emergency Care Board, Social Care, Primary Care and Community Collaborative, and the End of Life Committee. Now, I know that they're probably all related to one another, but I definitely don't want this transformation to be, so a kind of great big giant that creates a huge amount of bureaucracy that would inhibit the good running of the services and hold things up. And I don't think the report tells me how any of that's going to work. And the thing that I was really disappointed with is that, okay, if those boards have to exist and if they can be streamlined, so much the better. But I noticed that they're practically all NHS-led. And people will have heard me say many times, your organisation, Mark, is the Health and Care Partnership. And that C stands for care, not Cinderella. And I expect us to have a really strong profile in this. And I don't think, I'm right in saying, I don't think that our senior staff were asked much about what was going into this report and how they felt about it. And I wish that had happened. So my confidence is inhibited by the things I've just said, is positive because the report does recognise the things that I know need to improve. I'm very pleased, for example, that there's going to be a blueprint for ophthalmology, pharmacy, dentistry and podiatry. Every single one of those services is under pressure and none of them have got the kind of access that I would want to see for people in Medway. So I feel positive about those things, but as for how long it's going to take, and to refer to a point that Martin made, to what extent that's going to cause instability in the workforce and make it harder, not easier, to recruit the people to be needed, I think is in the lap at the moment. So coming on to improvement, if the things that I would like to be resolved can be resolved, and a timeline properly identified for achieving them, and if the health and care partnerships, which are of course are place-based, feel that they can cope with what I suppose would be the kind of operational delivery of some of the service improvements, then yes, things will improve. But all of the improvements at the moment, I feel, have got a question mark over them because they depend on the extent to which the review itself can include everybody it needs to and bring them along in a context where, of course, no one's starting from zero. These services are running now, people are waiting for them now, people are in them now. And these things have got to happen while we've got people still streaming through the door. And I would remind my lovely friend Jane that some of the things that the hospital is doing to manage demand, like wanting us to discharge people quickly, for very good reasons. I was at the Council of Governors last week. On that day, there were 120 people in Medway who had no right to reside but didn't have anywhere to go, and we've talked collectively after that about what we can do about it. And for the committee, some of those people are homeless, and we don't always know where they've come from, and they haven't got anywhere or a family structure to be discharged to. So there's a collective heads together on things like that. But that puts pressure on us and on primary care, and so do things like the virtual wards, where people, will have a procedure, quite a complex procedure in many cases, and go home very quickly. They can be in contact through the virtual ward with the hospital, but actually, if they need a doctor, it's probably going to fall onto their GP. So we've got to think about, how every action creates a reaction somewhere else, and prepare ourselves for the additional resourcing that's going to need it. So I think the potentiality for improvement is there, but how long it's going to take and how transformative it will really be, I think that there's a lot more to come.
Thanks, Councillor Murray. Councillor Wildy.
Thank you.
Councillor Wiley, hold on. Ivan, sorry, I'm going to let you in because I thought it's not gone. I didn't let you in last time, so I don't want you telling me off this time, so go.
Thank you very much. I just wanted to just clarify, probably agree with everybody, but also clarify something. So I think we would be sitting here with you irrespective of whether the contract was coming to an end, because we want and need to transform these services. So we would have this conversation about how we're engaging with the population in Medway, all the stakeholders in Medway, about changing these, transforming these services to stop those 120 people being in those beds because they shouldn't be there, whether it's at the front end when we're treating them in their home preventatively through community services, or at the back end getting them out quicker. The procurement is a separate issue, and the desire for us is to get through this process so when we do the procurement, we're commissioning the best service possible because we've been through this piece of work. If we can't do this in the pace that we need, as Jane says, we need to do this now, as Martin said, we need to do this now, then we will still need to go to procurement and then have a provider with 50%, 60% of this in place, and then work with that provider, be it the current incumbent or a different one, to then continue this journey. So I think we're all saying the same thing, we just need to be clear about the differentiation between those.
Thanks, Tyler. Councillor Wildy.
Thank you. I think it's a very good report. It promises much, but there is a process, and part of that process is this Overview and Scrutiny Committee on behalf of Medway's population, because we do represent our population, both sides. We've all got people and residents that we work for. And this seems to have been brought to us at a very late stage when much has been decided and there is much change in this. And then you ask us the question about, is this a substantial variation, where the report really answers that question, but we'll probably come on to that later. But I'm assuming we as a committee don't particularly want to slow this down, but it does have to be looked at in a proper and a thorough way, not just by yourselves, but by others. And I'm sorry, that's more of a comment, but if you wanted to say your view on that.
Thank you very much. So I agree. I think the bit that I'm struggling with is that I came in December and I was asked to write a paper over the Christmas period, which I did do. And like many people here, I was also working over Christmas, so I was on call as well. So this is work that's being completed. So I think it might be a little bit rough around the edges, and I recognise that it needs some further refining, but I think I'm quite honest and open to say, actually, I did say it needs to be socialised in that wider field with the HNCPs to get the sort of the public acknowledgement, the public engagement. So I don't think this is the finished article. I think, as I said, we're on a bit of a journey. We need to do the engagement. I need to come back in a couple of months' time and say, here we are, we've started to refine the pathways. I think I also will say, we started off with an ambition to transform 11 services. We're not going to be able to do that in the time frame that we've now got. So we have focused on 3 or 4, and as you know, Martin's alluded to, we probably just need to review that and make sure we've got that right, because that was me sitting down, testing this with a few people. I didn't have an opportunity to do the sort of the workshop, the wider engagement.
Councillor Cook.
Yeah, thank you so much for that, Mark, because that's pretty much what I was about to ask. And I think I asked the question, I think possibly of you last time, about KPIs, and we spoke about that balance between the strategic oversight and then moving down into the more operational KPIs of each area. And I think that's what really stuck out to me is, you know, there's even in those first few paragraphs, we think these are the top 4 ambitions. These could be the most important. We may cover the next 8. And that was exactly my question around, so does that mean that we won't come to ageing well for 18 months? Or will it be 2 years? And so I think that's what I'd really be asking for, is that kind of, you know, now in the next process, more of a breakdown around, well, why these 4? What's the cost benefit? Not in the minutiae detail. I understand this is, you know, the big picture, but what's the cost benefit of doing that now rather than that? Why have we chosen that over this? And when will we come to this? And then with the continuity of service question, and what does that mean? What's the kind of loss in the meantime for the existing service? So that's exactly what I was going to ask. Thank you.
So that's a really interesting point, and I suppose with hindsight what I should have done is said there are 11 ambitions. At the next workshop, I'm going to get the public engagement to decide what are those 4 priorities, because we can't do those 11 in the 2 years, the 18 months, because we just won't do them well, and we want to do them well. So yeah, on reflection, maybe I should have just said, here are the 11 priorities. At a further date, we need to define which are our top 2, 3 or 4, which are achievable in the time frame that we've got during that contract extension period.
And sorry, I can't help being an accountant and liking your data-driven piece. So there's a piece for us.
Ivor, can you go to the microphone?
Sorry, being an accountant and the data-driven piece, because there is a bit, we need to get the biggest bang for the buck, and how we can alleviate the pressures in Medway Hospital and keep people treated away from there. So there's bits of us around reviewing the investment we made over the last 18 months. What's given us the best benefit? Can we expand and roll that out? Do we pull back on some of the other bits? So for me, that data-driven piece will also help, and bring it back to you.
So Cook.
Just to come back really briefly on that, I think even that kind of, whether it's numerical or whether it's RAG rated, around what does it mean for Medway if we do one thing rather than another? Thank you.
Thank you, Councillor Cook. Have we got any other member?
Chair, sorry, can I just come in back on that question? Sorry.
I will let you, just on this occasion, Mike, because I wasn't going to let everyone come back.
Sorry.
Go on.
Just on split, I think that's the work we need to do together, because as we know, patients don't fit into one of those 11 boxes. So if you look at integrated neighbourhood teams, it'll probably hit 3 or 4 of those in one go. So I think that's the work, as Mark said, that some further thinking really engagement with how do we co-design and sort of, get jointly on that, then you could say, actually, by doing this piece of work on transforming these services, it hits a number of these parts. So I don't think it's quite, as the paper, you can't just segment it into those 11 areas. Thank you.
Thanks, Maritime. I think from Mark and Ivor, thank you for your comment earlier. I think it's, the comments you'll hear is because of the journey we've been on. That's the issue. And it's not Mark's fault, I'm going to say that. But he knows when I start saying that, he starts to worry, okay? Because it isn't necessarily his fault, but we've had to fight, and Mark, you will agree, I think, and I'm not saying you've done a lot of work over Christmas, and thank you for that, but we had to ask you for that vision, okay? Now, we had this presented to us in September, we were asked to approve this, and I do understand exactly what Jane and Martin are saying, okay? Sorry, members. And I do totally understand what you're saying. Something has to happen, and it has to happen quick. We know that. This committee agree with that because we see change is really important and we see that change is needed. I think it's the way that the process has been presented has caused nerves within this committee because it's changed every time. So when you plan a procurement process, you expect that procurement process to be very clear, very precise, okay, and laid out. And that's exactly how it was laid out to us at the very beginning, that this has to happen. We've got it all organised. We know exactly what we're going to do. I know you're going to. I will give you a chance, Mark, to come back. This is exactly what we're going to do, and it's all organised. And actually, it's not, is it? It's not organised because there's a lot more work. The vision's there, but you've still got to do a lot more work. And every time you may turn a stone over, something could change. And that's where, members, we talk about substantial variation. Because substantial variation isn't saying to you, we're making it difficult for you, you're not going to do anything, because you still carry on. All it means for us is that we have, which I believe, and I will harp on about right at the end, we should have had with you from right at the very beginning is an open and transparent relationship. That's what we want. We want that as a committee. And we haven't totally had that all the way through because we've had to fight for the information. So, I'm not asking for your forgiveness that members are nervous. Members are, Councillor Cook asked, as not the first time you've asked that question around KPIs and stuff. But, Jane, you're saying that we need to see what comes out of it, we need to see what happens, because of course you're desperate. You're desperate to see, hopefully the ICB help with your bed days lost, your 1,200 days, and how they're going to fund and help that resolve its problem. But I start to worry, when you're saying you're going to help health inequality and it's going to be resolved straight, that becomes a worry for me because where's the detail? The detail needs to be there. And I do worry about the bureaucracy. It's going like back in the old days. I say the old days, here I am as if I'm getting on now. But I think when you start seeing board after board after board, you worry about things being lost in that chain. And I don't see anything being patient or community-led. And that worries me. And it may come out in your process now that you do need to have that. And I'm going to say again, and it's not me having a go at Health Watch, please don't think I am, but it's not all just Health Watch. Right, Councillor Shocker said earlier in an earlier thing, and other members as well, about that community voice. It's not just Health Watch, it's others. And I'm not seeing anything led there in these, I'm not asking for ONS to have a space in that area, but actually, I think it is about time that your chief exec and your chair realise that ONS plays a part in all of this, and they really do need to, because I still don't think they've got that. I really don't. And that's not against you two, and please don't, but I do not feel they've got that. So am I nervous about this process? Yes, I am. Do I think it needs to go ahead and you need to start muddling through it? Because do I feel that something needs to change? Yes, I do. But do I think it's a substantial variation? Most definitely. But that doesn't stop you cracking on. What that does for this committee is for us to be able to call you back to get detail and to assist and to help and to support. That's what it does. Let's not all think SV is terrible. It's not. But it allows us to build that relationship and trust, which, Mark, I hope you would agree, we did lose it a bit, didn't we, at the beginning? Through the history, we've lost the trust. Or maybe we need to start building it. But this gives you the opportunity to start building that with this committee. And I'm going to ask Leanne, maybe Leanne, we need that meeting. Whether there's a couple of members of us, we need to meet with Sedi and the chief exec to make them hopefully realise to tell us what their ambitions are. I shouldn't have had to squeeze it out of you what the 11 ambitions are. They should be clear in every ICB top senior executive's mind what your 11 ambitions are. It should be something you ring off your mind or your tongue all the time, but it didn't. Yeah.
Thank you, Chair, and your request is noted. If I could give a view from corporate or the executive arm about this, I mean, the community services transformation needs to sit in an integrated system. So I think we're all agreed on that. But there are some ingredients, I think, that we need to be mindful of. We need to be mindful of consultation. We need to be mindful of co-design or partner design, patient resident's voice. We need to be mindful of transparency. And the key for me is a defensible decision. So made in a timely way by the accountable body, whoever that is. It could be the local authority, it could be the ICB in this case, it could be the acute trust. But as an integrated system, we absolutely need to get to grips with that because it will give confidence in the system and improve trust. Because I think this evening, trust has been mentioned on several occasions. And I think confidence in the system actually improves trust. It improves trust amongst partners for a better outcome for, in this case, the residents of Medway. So I note your request and I will act on that request. But from my point of view, those ingredients must be recognised and respected amongst partners if we are going to move forward with an integrated system. Thank you, Chair.
Thank you, Dan. Exactly right. So, Mark, did you want to come back very quickly? Maybe not going over the history again, but...
I'm not going to go over the history, but I think maybe the mistake we've taken is that we've been trying to navigate a course where we don't breach the procurement regulations and we have attempted to be open and honest. But I think, we'll go away and we'll reflect on how we handle that, because I agree it got a little bit difficult for a period. But, and as I've said to you previously, I'm keen that we have that open relationship. We need your help and support in a number of key areas. So we can't do this on our own. It needs to be, as a Medway system and as a Kent system. It can't be,
Can I just add, and again, going against my accountant nature, I'm going to try and be half full rather than half empty, and recognising the challenge around the history. We want to keep bringing this back as well as you calling us back and doing this in an integrated way. And I would hope, actually, that we could use this as a way of building that trust and relationship. So let's take this forward as a way of engaging and doing that.
Thank you very much. So members, I'm putting a proposal forward for a substantial variation. It's not a negative. It's to improve relationships and to move in Jane and Martin's right direction to get things moving. Do I have a seconder for that? I've got double seconders. So I've got Councillor Cook and Councillor Waddy. Waddy, do you want to say, Councillor Waddy, do you want to say anything?
Oh, yes, with the substantial variations and the way we work through it, obviously we do not want to slow down their process, which you've already said. So just the democratic officers that, will do the process should be mindful that, we wish to take this forward as quickly as is reasonable without undue haste.
And I think that's already, because Mark has already said that he needs to go out and do loads of consultation, and actually that's what an SV requires you to do. So there's nothing new, hopefully, because that's what you've said in your paper you're going to be doing anyway. But I do take that on board, and definitely take on Councillor Cook's comments around them KPIs and around that, because that's the question you'd probably be asked next time is about. I know Councillor Cook would definitely ask you that question about that journey and about making sure that there's evidence-based improvements, so make sure that's there. Is that, so I've got a seconder, is that agreed, members? Agreed. Thank you very much, and thank you very much for all your time, and Jane, have a nice holiday. Thank you very much, and we'll see you on Saturday morning. Mine. Take care. Thank you very much. So we now move on to our last item, which is item 8, which is the Kent and Medway Safeguarding Adult Board Annual Report. We're terribly sorry to keep you waiting. Maybe you found it quite interesting to sit through the process. Excellent, good. Exactly. Well, at least you're not worried about sitting in front of us. That's the main thing, Andrew, so that's very good. So could you just introduce yourself, Andrew, because we've got new members here as well.
Can everyone hear me okay? Thank you. Sorry. My name's Andy Raby, and I'm the independent chair of the Kent and Medway Safeguarding Adults Board. I'll let Vicky introduce herself and then talk a bit further.
Hello, evening. I'm Vicky Whiddon. I'm the Kent and Medway Safeguarding Adults Board Manager. Thanks.
Andy, can I just say, obviously, as per usual, you give us a really good, thorough report. It's very thorough. So if you could just give us a short highlight, that'd be really good. Can I just also just say, though, because it's so thorough and because it's always really to the point, there were some members that found some of the case, which you understand, they found some of the case studies quite upsetting. So if we can try and steer away members from going into those case studies too much, I would really appreciate it, because it was, some of them cases you dealt with were quite harrowing, and it certainly triggered many individuals with regards to those stories. But thank you for putting them in the report, because they were really important. But I don't really want to touch on them too much tonight, if we can, if that's all right, Andy.
If I could just mention that point you raised, and if I give my apologies for that, it's something that we have to do. We're actually instructed to actually write about the safeguarding adult reviews within the annual report. They are all published documents, and they are harrowing, and you know, we all find it very difficult in relation to them. So I appreciate that. No, we wouldn't be going to those.
No apologies needed, Andy. It was just because I know you have to put them in. I just wanted you to be aware that I don't want some members triggered with it. So if we don't have to touch on it, but please give us your highlight. That'd be great. Thank you.
Okay, as you say, it's a very large report, and so it's very difficult to actually draw anything particularly out. Obviously, this is Medway. And at the last meeting I was at, Councillor MacDonald, you asked me whether we could separate the two, which is very, very difficult, because most of the agencies that we deal with are across Kent and Medway. So we gain information, we put it together. However, we are going to attempt next year to actually see whether we can separate out some aspects of it, because some aspects are reported on individually. So the information that you get in relation to the Section 42 reporting, which is the reporting in of safeguarding concerns, care and needs assessments, is Medway and Kent divided, so we can do that. And then we always ask for examples of where people have actually dealt with our strategic priorities and examples they can give across those three priorities, which is also something we can and we will try next year to actually achieve. Vicky's come along this year because she is the author. I've sat here alone in the past, taking all the glory, all the credit, but the truth of the matter is that Vicky does all the hard work. So hopefully she can help with any questions you have to ask. This is an annual report. It runs from April 2022 to March 2023, so it's always a little bit behind, but of course we can answer questions about current things and issues that are going on as well. I don't think I am going to draw out anything in particular. I think it's important to allow you time to ask us questions and for us to try and actually help with the questions you have.
Thanks, Andy. Members. Councillor Printer.
I was just going to say thank you for the report. Thank you for the report. And yeah, don't apologise for putting those stories in. Those people, their story needs to be told so that we can learn from it. And then if you pick up any one thing that's going to stop someone else getting, they're worth putting in. So that was all I wanted to say. Thank you.
I think if I could just say in response to that, because I think it's a really important point, and some of the things that actually you've discussed tonight are the things that actually make that difference. So we speak a lot about hospital discharge. We've recently challenged around hospital discharge because it's really important to understand from a safeguarding perspective how a good hospital discharge, and what does that look like, is actually effective in actually protecting people's lives in the future. So all of the things that you say come out of a safeguarding adult review actually are collected, recommendations are made, and action plans are put in place to ensure the things that are found out in those reviews are taken forward, and we then measure to ensure that improvements are made as a result of that.
Thanks, Andy. Councillor Campbell?
Thank you, Dan. Wow, what a report. It was enlightening, it was inspiring, yes, harrowing in parts. I just learned so much from that, just reading that. And also, it's actually remarkably reassuring to know that there is so much thought into reviewing and learning and curating the process, and so many kind of structures and frameworks in place. So I think for me particularly, I know they might be minor, but I really like that you've, for example, translated your leaflets into so many languages to make it more accessible. There's simple things like that. And I also like that your leaflet has been adopted by the boards in other areas, was it? Yeah, putting Medway on the map. That's excellent. One thing that came up, looking at all the case reviews, multi-agency working is a common theme, and you have picked that up. And that's kind of a standout. I mean, it's kind of very rudimentary, isn't it, when you think about it? It's common sense, like vulnerable people have to navigate so many people and so many things. And I kind of sometimes, I have to admit, I feel a little bit hopeless about multi-agency working when it comes to our social care networks and NHS and things like that. People just have to go to pillar and post and repeat their stories and their experiences in so many different places. So I just want to see, are you actually seeing any progress with that? Do you see that improving in terms of multi-agency working? Thank you.
Yeah, thank you. That's a really good observation, and I think we are starting, and it's more this year now, in terms of improving our processes. As a board, we've looked at best practice elsewhere as well, and we're implementing a multi-agency, or we're in the process of discussing implementing a multi-agency risk management process. So we're in the process of designing that, getting sign up to that, and that will be about how you come together for those really, really, really high-risk cases, individuals. So it's about that's going to be, for me, that's a really heartening development. But I think you can actually see, and I think you see it through the number of safeguarding adult referrals that aren't progressing, is that sometimes agencies put the referrals in, and it's right and proper to do that. And when we get a referral, we ask for a summary of agency involvement from all the agencies that were involved in that individual. And the biggest reason why they don't then progress to the SAR, the Safeguarding Adult Review, is that in getting all of that information together, we can see that agencies have worked really, really well with that individual. So that area of the criteria isn't met. So I think we are starting to see some improvement there, and there is a lot of positive work in that area. So, thank you.
If I could just add to that as well. You're absolutely right. Collective responsibility is what delivers great safeguarding. Because actually, when you think about what safeguarding is, it's about safeguarding vulnerable people. And those vulnerable people don't just exist in one domain of health, policing, adult social care. They cut across them all. And what I can say here in Medway, which works really well, is we've got a great relationship with the CSP. Because it doesn't just exist within adult social care or children's partnerships or in relation to community safety partnership and criminal justice. It exists across them all. And you wouldn't believe how difficult it is to join those together. But here in Medway, we're actually able to do that quite well. So we have a good relationship with the CSP. We do joint work in relation to some of the things and the opportunities. So self-neglect, which is a really important aspect that comes up in something like 47% of our SARS. Self-neglect is a common theme. Mental health, understanding issues such as mental capacity are all really important parts that go across different boards. And every year I say we need to do more things. We need to identify themes that actually cut across them all. Even if we did one thing and said we are going to all together here in Medway focus on this. And at the end of the year we can say, and look what we've achieved as a result of that focus. So you're absolutely right. It's work in progress. I work incredibly closely with Jack and Leanne, and we do have this common vision, and I think it's really important that we sort of keep that going, and that's where you as councillors help us in relation to achieving that.
Thank you, Councillor Campbell. Councillor Wiley.
Thank you. I will keep it to about 3 questions. On page 88 of our report, 87, which I think is 27, page 27 to you. There's a chart which shows the SAR referrals are going up each and every year. Now, is that better modelling, if you like, or is that people's situations are getting worse? There's more cases reported?
It's difficult to say, and that sounds a really crass answer, I know, but it is true because circumstances in people's lives change, pressures change, issues affect the reporting issues that happen, but equally we do see a greater awareness in relation to what a safeguarding adult review can do. So, for instance, the introduction of medical examiners, which now sit and work alongside coroners, has actually added to the number of people referring to us. So a medical examiner who will talk to somebody and family following the death of a relative will now start referring things to us. Greater responses from policing, etc., in terms of referring things in. We have often a very much of an overlap between domestic homicide reviews and safeguarding adult reviews, so we'll see those increase as a result of that. They have increased over the years. I would say the amount of effort we put into an awareness raising as a board has that consequence that people will actually engage with us. We have a website that has thousands, hundreds of thousands of hits per year, per month. I mean, when we put out our new strategic plan, there was 923 visits straight after that plan went out onto that site. We put out a newsletter to 300 different organisations every single month that sets out, and each one of those has the reporting mechanisms around safeguarding adult reviews. So it is a combination. I think it's more to do with the fact that the awareness raising actually makes a difference.
Victoria, Jackie, did you want to touch on that as well? I'll come back to you, Victoria, as well. No, Jackie and Victoria, I'm saying as well.
Okay, yeah, thank you. Yeah, I think so. I'm going off now, sorry. Yeah.
Sorry.
So I'm just sort of giving some more information from what Andy's saying. So in Medway, we've seen an increase of 69% over the last 5 years of referrals, so safeguarding referrals. So definitely the awareness is known. With regard to the safeguarding adult reviews, when a situation happens to a person in Medway, the team will really look at that and determine, does that need to go for a safeguarding adult referral, and they'll pass that across to the team, where then a decision is made about that. So there's the increase in the number of referrals coming into adult social care, but I think the knowledge in the teams about what should and shouldn't go through to the SAB is also, goes towards that too.
Thanks, Jackie. Victoria, did you want to tap on?
Yeah, just a quick one as well, in terms of we've got our self-assessment framework that we spoke about and it's written about in the report, and that goes to 32 different agencies, and ever since we've started, so on a 2-yearly basis, we will say, how do you make your staff aware of the SAF, of the SAR criteria and what's your process for raising that with us? I don't think any other board does that, so I think that's you know, I think it's a very fair process in trying to make sure that our numbers are right, really, that we are hearing about the cases that we should be looking into and learning from for the individuals. So,
Thanks, Victoria. Councillor Whitey, next question. Your mic, Councillor Whitey, your mic.
Thank you. Do you want to sit next to me? You can't, no. I was going to discuss one of the cases, but it's not really necessary. A few of the cases you write about had mental health issues and had been in an acute bed. And earlier we heard, excuse me, how in Medway and Kent, people were in an acute provision less time than nationally. Do you think that helps or hinders the individual situation? And I know that's a difficult question because every case is separate, but...
With the Safeguarding Adult Review, we have an independent chair, and that independent chair has a skill and an understanding of safeguarding practice. And we ask them to make recommendations to us of what they think needs to change and can be improved upon. You've got to remember, a Safeguarding Adult Review is not a process to actually attribute blame. It's there to learn and to share learning. So we're very, very careful about that, because if we change that, what we do is we don't then get the engagement of agency into the way you need to have it. So when we see recommendations come out, we make sure that we deal with those in terms of an action plan. So we actually focus them. What we do, which I think is the point you're making, is we look and we can see holistically issues and areas of concern that actually become repeated. So when we see those repeats, then I will, and I'll give you an example of it, I will actually go to an agency and actually ask the question, what's happening about this? And I've recently done that to the ICB about hospital discharge. And the reason I do that is because it's our responsibility to actually challenge practice to ensure that adults are safeguarding. So you're right to raise it. If it comes out and it's repeated, we wouldn't do it on a one-off. We would actually still have a recommendation, but we look for a significant degree of evidence to base our challenge on. So on the hospital discharge, we looked at previous SARS going back over years. We looked at current, and we looked at new ones that were actually coming to us that hadn't then been written. So that's how we tackle it. I hope that answers your question.
Yes, yes, thank you. And my last one is a small question, but again, it's just the language that's used. There's, on page 122, defensible decision-making, and as this is a public document, that just seems a bad choice of words. In my view, that could be misunderstood quite easily. You know,
Are you looking for an alternative? I mean, I take your point. I suppose it relates to a language that people understand. But actually, your point is a good one. It's a public document, and the public reading that may not understand what that means. So, yeah, we can take that away as an action to look at that.
Now, they may see that as you are defending instead of looking dispassionately at something. But anyway, if you take it away and look at it, thank you.
Thanks, Councillor Whitey. Councillor Brate, your question, please.
Yes, thank you. Thank you for the report. Excellent. So much effort and energy has gone into putting the report together, and I personally always find it extremely good reading to see exactly what's going on. I obviously go for the bits connected with Medway, but know that this is a joint Kent and a Medway document. You touched on the successes, whether it's what has been brought to the attention of the board, the way it's been handled, the way it's been dealt with by the local authority or other agencies required to sort some of these issues out. But what I don't see in there, unless I've missed it, is how many individuals actually come back into the system once you've seen them, or once they've been referred back to a local authority. Is that information available, or is it...
That's a very good question. And it's a question I ask frequently, because I think one of the important things we have to remember, and I think this is why Vicky touched on the MARMA process as what we're looking at, is because what we do see is the way the system works and the way the numbers are counted, they'll count individual referrals in. What it doesn't do, and it doesn't have the ability to do, unless Leanne and Jackie can tell me differently, it doesn't have the ability to identify, did Andy Raby come in 10 times to be dealt with in the same way? And what we've identified is actually, if we're going to tackle some of the long-term issues, we're going to need to get into understanding maybe who those people are, so we can actually support them holistically and as Councillor Campbell has said, together with other agencies in a different way. And I think it's a good question. I think nationally there has to be a better way of counting this, and we've asked for some analytical report. We haven't got any analytical support, but we would like some, so we could actually start getting some of that data a bit better. We're very lucky here in Medway. Every month we get sent through data, and we're kept up to speed in relation to the data of referrals into us, so that's helpful for us. But it's a good point. Thank you.
Jackie, did you want to touch on for Councillor Brake as well?
Yeah. So, I mean, we can do that in Medway. So we would be able to see the number of safeguarding concerns that are raised, and if there's a repeat. And it's something that we look at generally. So if a case comes in, I can see immediately when I'm looking at a person's record if there's been a sort of revolving door as such. And you'll see, we talk about I can't even say it. We talk about professional curiosity, and that's something that we're working on with our teams, is to make people think, actually, if there's been 3 safeguarding concerns, why is that? And, get to the bottom of that to see what the bigger picture is.
Thanks, Jackie. Councillor Brake, did you have anything else to add?
Sorry, just one further point, if I may, please, and that is that the point was raised about the significant increase in referrals. Quite honestly, in the past, when that actually happened, and I was part of the administration, yes, initially it did raise concerns, but from that, what we picked up was the fact that we now had, and we were living in a community that did not feel afraid or ashamed to raise an issue, and all of the issues that were raised were, I say all of the issues, there were 1 or 2 spurious came in, but the majority were in fact honest opinions. Some people were very concerned and they showed there was nothing untoward, but it was something that was raised, and I think that is it is very much a plus point for people to know that never be afraid to speak out.
Thanks, Councillor Brake. Thank you very much for that. I suppose for me, Andy, you're lucky it's not a whole list of questions for me, so don't worry. I just want to touch on one, I suppose, is around lessons learned. Because, in the press today, we've got an awful case, allegedly an awful case again, that's going on, and then people start to look around their own areas, don't they, and see what, with regarding social services, police, etc. I just want to ask you, when you do your lessons learned, when you do your process, do you really feel that the organisations you're dealing with do learn those lessons? And do pick up on recommendations and don't fight back on them?
That's a difficult question. I mean, we do put a lot of effort into this because more and more the SARS are becoming our bread and butter. And we identify themes and we identify issues of learning, and we do repeat them quite frequently. So if I give you an example, I left police in 2014. I did a domestic homicide review in 2016, and one of the recommendations I made in that, and it wasn't in Medway, was in relation to support for carers, because the Care Act had just been introduced carers were a big issue of it. I read a review the other day and the same recommendation was being made. Now, that's not to say progress isn't made, because there's very many areas that it is. Self-neglect is a good example. We've put a lot of effort into self-neglect. We have a multi-agency practice in relation to that, and we're able to monitor the delivery of activity around self-neglect in a way we never could. You know, if a person was self-neglecting, it was previously considered a choice. Now, we know better than that now. We know better in relation to their issues around mental health, the issues in relation to capacity, and how we can better support them to actually come out of that particular issue that they're actually, that they have. So I think people do learn. I think it's a long process to actually change people's approach and views. We have a new approach now to our training. We've actually got 2 new trainers who are coming in. One actually used to be here at Medway, actually, funny enough. And their job is going to be to try and embed that training actually amongst our strategy partners. One of the things I would like to see is training widened out to more community. We now deliver webinars, which everyone here is invited to attend. We do them on a quarterly basis. They're free to attend, 6 o'clock in the evening. It's an hour, then half an hour questioning. And we always bring topics that are pertinent to adult safeguarding. So we've had blue light services in relation to drink and drugs. We have mental capacity. There's one in there, Daphne Franks. Who spoke at predatory marriage, etc. And we've put that on to allow anyone to attend, and councillors do attend. So we try very hard to actually widen and broaden the sort of way we put out things.
I mean, I would certainly recommend them. They're excellent. The webinars. Can I put the question to Jackie and Leanne? Then maybe it might be easier with regards to staff and when a safeguarding incident comes up. How is it so much of a scary process for them straight away? Does that defence mechanism comes up? Because 99% it's not always there. It's a learning thing, isn't it? Really. So, do you find it pretty easy how your staff with your managers go into the procedure and get involved in it and learn from it?
I mean, so obviously as the local authority we have the statutory responsibility. So with the safeguarding concern comes in, we review that and make the decision about whether it goes on to an inquiry. And in the report, the Medway data is at the bottom of that. We have a safeguarding team who work specifically on safeguarding. So some local authorities will mix that across the locality teams or their operational teams. But we have a dedicated safeguarding team, which actually Leanne's been leading on some work to expand that and get some additional resource because of the increase. So they're very focused on that specific piece of work and bring with it a lot of experience. You know, you touch on the case studies, and obviously some of the people, you know, that's the sort of cases that they're dealing with, and so we need to make sure that we're giving really good supervision to them to make sure that, you know, as you say, you see things and they trigger you, they're dealing with those before the person passes away or before there's an incident. So, you know, you can become quite involved with an individual. With regard to lessons learned, so we hold an acronym, I'll change it. So we hold it's a bi-monthly meeting now that I chair. So it's the Safeguarding Adult Review and Domestic Homicide Review Board, where the senior management team and our operations managers attend, where we review all the actions that have come out of the Safeguarding Adult Reviews and look at what we need to do to improve, and then how do we share that? How do we make sure that the team... So we do things like lunchtime learning sessions, we'll put things out in bulletins, and then we look at the themes as they come back round. And, you know, so when there's another Safeguarding Adult Review that Medway Council has been involved in, we can look through that and see if there's been any sort of repeat patterns and, you know, have we learned? At the moment, professional curiosity is the key thing for us. That's the area we need to learn.
Yeah, just following on from Jackie, I totally agree with what Jackie said, but, you know, it is a tough gig, safeguarding. It is day in, day out, with very, very traumatic events. There's no getting away from that, and I want to pay credit to Medway's adult social workers who absolutely do a key job with the residents, with the at-risk adults, with our vulnerable adults in Medway. And I think, Chair, if I might say, how Medway looks after its social workers is a really key point. And Jackie has given you some examples of that today, but that duty of care we have for our social workers is extremely important. But while I've got the mic, Chair, I do want to pay credit to Andy and particularly Victoria about how well Medway is supported through the Safeguarding Adult Board. Both of them do a fabulous job. Both of them understand Medway, and both of them push and, back Medway's cause. So I just wanted to put on record my thanks to them. Jackie and I have absolutely said to Jackie that she and I, as senior officers, must play our part in this. And Jackie, I know, is the Deputy Chair of the Adult Safeguarding Board, and I chair the Quality Assurance Working Group. And we make sure, with the help of Andy and Victoria, that Medway is right up there and our residents' needs are being met. So thank you, Chair.
Andy and Victoria, I would just say that as well, because obviously I think new members, like Councillor Campbell said, found the report inspiring, but also, the detail was there. And we don't often always get reports that have the detail in that we require to give us assurance. And I think from a member's point of view, it certainly gave us that assurance that there is a body there working really effectively to make sure that this issue is dealt with. I suppose my only shout out is something that I could do with you, Andy, offline maybe, is that I think I know some members during their induction process maybe didn't get enough on safeguarding, and it'd be something that I think members would be really interested in, even on a webinar or on even to listen to some of your story, just the process. Because obviously we're overviewing scrutiny here, but the process and learning is really good. Even the SARS process is really good, and I think some members would really benefit from that. So maybe it's something we'd take offline and talk to you, but that'd be really appreciated.
Yeah, it'd be an absolute pleasure. We'd be very happy to do that. Thank you.
Vice Chair.
I move that we note the report.
Is that seconded? Seconded, Councillor Campbell. Agreed, members? Agreed? Thank you very much. Thank you so much, Andy. Thank you so much, Victoria.
Could I just indulge just one last second?
Go on, Andy. I know you will.
This is the first time I've been here, and I just wanted to thank Councillor Brake, who has been part of our board for the last 2 times that I've been here presenting. He's always been a great advocate for adult safeguarding, and I just want to note my thanks to him. Thank you.
No problem at all. That's brilliant. Thank you very much, Andy. Thank you, Councillor Brake. Thank you very much. Right, item number 9, work programme. Over to you.
Thank you. I have nothing further to add. I have checked in with Michael. He has not asked me to raise anything in particular, but if you have any questions, I will do my best or I will take it back for you.
Thank you very much. I have a few updates, just brief ones to add, is that for those that you just quickly on the work programme, many of you spoke. I know Councillor Wilding has spoken about it. The training programme is nearly all put together now. Visits to Medway Hospital, visits to Ruby Ward, some of the training elements that we're looking at as well. So it could be quite a few busy months up to May. And we've got MCH this Saturday as well for members that can attend. I would really encourage members to come along to these events because they are really interesting. I know some members have already been in there before, but MCH, for example, are going to be a key player in this procurement process, so we need to be in those meetings. But there will be. We've also. I'll be coming back to members about going to the brand new ambulance station in Twiddle. Behind the Asda garage there and everything else. So we're going to look at their new headquarters as well. So when we come out of a programme, please do try and make the effort. And there are times, for example, Medway Hospital, you can't really do that online. I'd like you to come and look around the ED department, and many of us have done that. But there are other ones that will do it online and be able to give you that overview, and then maybe organise a visit in the future. But that's what we're definitely working on. Okay, so that is the Vice Chair.
Thank you, Dan. I move that we agree the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in the italic text.
Is that seconded? Seconded, thank you, Councillor Cook. Okay, agreed, members? Really, thank you very much. 9:38, 8 minutes over to my normal time. It's not bad. Thank you very much. Have a good evening, members. Thank you.